Welcome everyone for the class on neurology. The first thing what we'll be seeing is headache. Headache is broadly classified as primary headache and secondary headache. Primary headache, we do not know the underlying cause. Why? What is the pathophysiology? We are not aware. If we do not know the pathophysiology, we call it as a primary headache. If we know if there is a cause for the headache or there is a pathophysiology for the headache, then we call it as a secondary headache. For example, a head injury, a trauma has caused the headache. Obvious thing, a vascular disorder like and there is a bleed in the subarachnoid space, or it is because of the alcohol withdrawal, or because of the infection in the brain parenchyma or the meninges which are covering the brain, or it because of a metabolic disorders like hypocapnia, hypoxia, or it because of a neuralgia, for example, trigeminal neuralgia. These are all secondary headaches. What are primary headaches? Primary headaches are important headaches like a migraine, tension type of headache, cluster headache, the few miscellaneous like benign cough headache. You cough continuously and you have an headache. Benign exertional headache. When you work, strenuous exercise you do and you have an headache. Headache associated with an intercourse. While having an intercourse, usually you have an, not usually, if the headache presents, it will be an occipital headache. So the presentation will be an occipital headache, but again, in sexual headache, you always need to rule out an SAH before you label it as it is a benign headache or it's a miscellaneous headache associated with a sexual activity. So the take home message here is primary headache, we do not know the pathophysiology. Secondary headache, we know it, either it is a trauma or it is an infection or it is a drug withdrawal or a neuralgia we are talking about. Headache is a common presentation to the emergency department. Whenever someone presents with a headache, we always need to look out for are there any red flags. If yes, there is a red flag, then usually we go ahead and do further evaluation, that is in CT scan, what we get it done, or CT head, what we get it done. For this reason, what we'll be seeing, you need to see, are there any red flags? If red flags are present, you will go ahead and get a CT scan done most of the time. What are the things what you need to look out for? It is a new onset headache over the age of 50. So someone who is 51 or any age more than 50 comes to you with a new onset headache, you will go and get an CT scan done. Few other things what you need to look out for, you can remember is changes in the character. First, it was a pulsatile kind of headache. Now it is a severe thunderslap kind of headache. So characteristic of the pain has changed over the time. There is any neurological deficit. It might be during the examination you have this neurological deficit, or it might be during the presentation. For example, it might be a diplopia, a presentation symptom, or on examination you found out that there is an upper limb weakness. That is a sign what you have found out. So any neurological deficit is present. Any signs of raised ICP, like papilledema is present. Any seizures are present for this patient. So any signs of raised ICP is present. For example, vomiting is present. Then you will go ahead. Signs and symptoms indicative of an subarachnoid hemorrhage, that is SAH. Occipital, severe headache, acute onset, someone presents to you, you need to always think of an subarachnoid hemorrhage. CNS infection, mainly we're talking about meningitis and encephalitis. Meningitis, someone who has a fever, headache, and vomiting, you're strongly thinking of meningitis. Fever, headache, vomiting associated with altered sensorium, you think of it might be an encephalitis also. So think of CNS infections. Any risk factors for CVT? We will be talking about the CVT and we will be talking about the risk factors like pregnancy, dehydration, anyone who is on OCP pills. These are all risk factors for an CVT. Anything suggestive of an temporal arthritis, like jaw claudication is present, jaw claudication is present, scalp tenderness is there, or there is some symptoms of eyes are present, especially any loss of vision is there. You are strongly suspecting an temporal arthritis. In this all conditions, you usually go ahead and further evaluate. Most of the conditions, you go ahead and get a CT scan done. For example, for temporal arthritis, you might do different investigations like here, and biopsy is the diagnostic of choice to label the diagnosis here. Usually we get inflammatory markers in the emergency department to support your diagnosis. So these are the same things what I put up across here. So along with the characteristic, look up for the frequency and association, the focal neurological deficit and non-focal neurological deficit like cognitive disturbance are nothing but neurological deficit, what I'm talking about, including this one. Headache that changes with the posture, suggestive of an raised ICP. Headache which wakes the patient up, that is also suggestive of an raised ICP, or it is usually suggestive of a very severe kind of headache. Headache precipitated by physical exertions or vascular maneuver also suggestive of an raised ICP. Thunderslap headache is suggestive of an SAH. Neck stiffness, fever, vomiting is suggestive of an infection of CNS infection, especially. Risk factors for CVT, the cerebral venous thrombus, we'll be discussing about more about it. Jaw claudication, visual disturbances is suggestive of an temporal arthritis. A new onset headache in a patient with a history of HIV, here also you need to go ahead and get a CT scan done. A new onset headache in a patient with a history of cancer, also you need to go ahead and get a CT scan done because it can be METs. These are the red flags, what you need to remember. If these red flags are present in your stem of the question, always choose for further evaluation. First thing what we are seeing is primary headaches. In primary headache, first one what we'll be seeing is the migraine. The different kinds of migraine. Migraine can be associated with aura, might not be associated with an aura. What is aura? Aura basically patients has flashes of light, some floaters will be seen, some blurring of the visions will be there, some tingling sensations over the hand or face. These patients over the time they would realize that whenever they have this flashing of the light, some color disturbances or some blurring of the vision, some floaters they see, they're gonna get an headache. So this they have termed it as an aura. One third of the patients with an migraine usually presents with an aura. Rest of them they do not present with an aura. Very minute of them might present a migraine with an hemiplegic. That is a unilateral weakness of an upper limb and lower limb is usually seen in a hemiplegic migraine. What is basilar migraine? Basilar migraine are usually the cranial nerves which are involved here. Then you call it as an basilar migraine. Is cephalic migraine. Neurological deficit is there, but headache is not there. All this are very rare. Okay, you cannot label someone who comes with an headache and an unilateral weakness and hemiplegic migraine unless you rule out an obvious stroke. Same thing holds good here, same thing holds good here. So these are not diagnosed in the emergency department. You need to rule out much more common causes before you start thinking of an hemiplegic or basilar migraines. How doesn't pay? What are the triggers for an migraine? Triggers for an migraine: someone who is a fatigue, increased alcohol intake, someone who is taking OCPs, oral contraceptive pills, someone who doesn't strenuous exercise or is under stress. Certain food materials or certain food like chocolates and cheese can predispose or trigger to migraine attacks. What is the clinical presentation? Classically, they present with an unilateral headache or only one half of the head is hurting them. And this headache is classically described as pulsating. So it is kind of pulsating headache what I'm having, doctor. It is continuously there and each episode can last for 30 to 1 hour's time and usually may last, sometimes it might even last for 72 hours. Most of the time, it is associated with some amount of nausea and vomiting. The headache becomes worse when you expose the patient to a bright light or becomes worse when the patient is exposed to the loud sound. This is known as photophobia and this is known as phonophobia respectively. Usually, they will have previous similar episodes. There might be a family history of migraine also might be present. What is the management plan? What is the NICE recommendation? So according to the NICE guidelines, what do they recommend for the treatment? Someone presents with a migraine to the emergency department. They strongly say that do not give ergoids or opiates, especially opiates should not be given because eventually they become an opiate addict, what studies have shown. So they strongly recommend not to give ergoids or opiates. The first line of drugs are usually what we treat it with an triptan orally and an NSAID what we'll be giving. Orally, it's important. The route what you're giving is important because it changes in a cluster headache. Triptan orally plus an paracetamol. So either with an triptan, you'll add up an paracetamol or you'll add up an NSAID and discharge them. Someone who is a teenager, that is the age between 12 to 17 years of age group, nasal triptans are present. That is intranasal spray of an triptan is present rather than giving them an oral triptan in those patients. What about in pregnant women? In pregnant women, it is best that you avoid the triptans. Just give an paracetamol. Still, the pain persists and the patient is not able to tolerate the pain. At that point of time, you add up an triptan. Otherwise, you'll not be adding up an triptan. You avoid an triptan. Paracetamol is the safe drug in pregnancy. Triptans to be considered if the pain still persists and patient is not able to manage only with the paracetamol. That's when you add up an triptan. Subarachnoid hemorrhage. What is subarachnoid hemorrhage? So layers, you need to have a little bit of anatomy. Your brain is covered by meninges. The outermost layer of the meninges, that is after skull, the next layer which comes is the dura mater. Okay, above the dura mater, there is a space known as epidural space. Below the dura mater, there is a space known as subdural space. Then you have an arachnoid space. Sorry, arachnoid space. Below the arachnoid space, what you are having is an subarachnoid. Below the arachnoid space is the subarachnoid space. In the subarachnoid space, if there is any bleeding, then you call it as an SAH, that is subarachnoid hemorrhage. So bleeding has happened in the subarachnoid space. Most of the time, this bleeding has occurred due to an aneurysm. Aneurysm where in the anterior communicating artery, 40% of the time, that is the majority of the time, it is in the anterior communicating artery. Anterior communicating artery is an artery which communicates between the anterior cerebral artery of the right side and the left side to form an anterior communicating artery. So it isn't communicating, it's like a bridge what is present. Usually aneurysm is present. Aneurysm, basically there is a weakness in the wall which causes a pouch, and eventually this pouch ruptures. This is the most commonest cause for an subarachnoid hemorrhage. There are other causes also like an AV malformation, meiotic, that is an infective cause for an aneurysm, an angioma, that is a tumor of a blood vessel, neoplasms or a trauma can lead to an subarachnoid hemorrhage. Traumatic subarachnoid hemorrhage usually have a good prognosis. What are the risk factors to have an aneurysm or to have a bleed? These are the causes what we have learned for. These are the risk factors what we are having. Connective tissue disorders, especially you're looking for an Marfan syndrome. Okay, a thin, tall individuals where his upper limbs, if you take together or add up together, are much longer than his lower limbs. You're thinking of an Marfan syndrome in this individual. Someone who is having an Ehlers-Danlos syndrome. Here also this connective tissue disorder, it becomes very flexible, so aneurysms can easily form. Someone who is having a very high blood pressure, polycystic kidney disease, coarctation of aorta if they are having, or who is a smoker, atherosclerosis, all of these are the risk factors for an SAH. How do they present to the emergency department with an SAH? With an SIH, usually they present with an severe headache, acute, hyperacute onset, severe headache, worst headache of their life, what they'll be describing. They will usually describe as an lightning has striken their back, thunder slap headache, they call it. This kind of severe headache within seconds, if not within fraction of a second, has reached to its peak and it is behind the head, that is occipital region, the patient will be having headache. This is the classical description of an headache. Along with this, there might be a few other things like vomiting, neck pain, photophobia. They're not very specific. They might be associated with it. There might be a syncope attack. Low GCS might be there. These are the things what usually the patient presents to the emergency department. But whenever a patient has an SH, if you take a thorough history, usually they'll have an warning headaches. As an emergency physician, it is expected of you to pick up this warning headaches whenever the patient presents to you with an warning headache. What is an warning headache? With an trivial movements, usually they have an headache. For example, I lifted my hand up to pick up a book and suddenly I had an occipital headache. It is not worst headache of the lifetime, just a normal headache, but it is associated with an physical activity and the headache is in the occipital region. These are the warning headaches. It is slowly oozing out from the aneurysm. It has not ruptured it from the aneurysm. If you can pick up at this, then you can prevent the catastrophe. You can save the lives also. So picking up at the warning headaches itself is and challenging for an emergency physician. It is difficult to pick it up. Most of the time it is missed unless you are very experienced and you are always thinking of a warning headache. Fundus, usually it has a classical picture, nothing but it is an retinal bleed what is present, which is very close to the optic nerve or the optic disc what you are having. This is known as subhyoidal retinal hemorrhage. Sometimes these patients might have an focal neurological deficits also. But the classical description is sudden onset of occipital headache, very severe, acute onset, and reaches its peak within few seconds itself and presents to the emergency department. Always think of an subarachnoid hemorrhage unless and until proven otherwise. What is the first investigation you get it done when you are suspecting an SAH? Is a CT brain plain what you are getting it done as the first thing? Whenever you get in signal, it's a massive bleed what you are having. Usually we get an appearance like this. This is supposed to be looking like an frog. So what you're looking as white is the bleed. Where is the bleeding is the subarachnoid space. And it's supposed to look like an frog. That's why it call it as a frog kind of bleed or This is the classical bleeding appearance on a CT scan, what you'll be having SAH. But if it's a minute bleed, it may not be picked up on NCT scan. What does the latest guidelines say? So I'm talking about the latest guidelines. Few books might not have updated this one, but this is what is being latestly followed. Nowadays, the CT scans are sensitive enough to pick up even a minute bleed in the subarachnoid space if presented within the 6 hours. If it is more than 6 hours, then CT scan cannot rule out an subarachnoid hemorrhage. You need to get an LP scan done. LP done. That is a lumbar puncture done and look for xanthochromia. So basically what you are doing, you are suspecting an subarachnoid hemorrhage from the history what you are having. So immediately you will go ahead and get an CT plane done. Okay. Then you need to see whether this CT plane is done within 6 hours or it has been more than 6 hours since the onset of the pain. If it is more than 6 hours, if the CT scan is negative, also what you will be doing, you will be admitting this patient. Why you will be admitting? To get an LP done to look out for xanthochromia. When you will be doing this LP? After 12 hours of the onset of the pain, because xanthochromia doesn't appear, that is discoloration of the CSF doesn't happen within 12 hours of the onset of the pain. If the patient has presented within 6 hours of the onset of the pain and the CT scan comes as a negative, then you have ruled out an subarachnoid hemorrhage. You need to think of something else. So remember this, this is the latest guidelines what has been followed. Lumbar puncture, as I told you, needs to be done after 12 hours of the onset of the pain. Do not do it before, because if you do it before, we are basically looking for xanthochromia. Xanthochromia is nothing but discoloration, yellowish discoloration of the CSF. Normally, it is colorless. It becomes yellowish color if xanthochromia is present. Opening pressure might be increased. Gram staining obviously will be negative, or there will be no bacteria at all. Elevated proteins might be there. WBC cells may occasionally slightly elevated normal glucose. So most of the things will be normal. Only two pathologies what we'll be having is raised opening pressure and xanthochromia. Raised opening pressure is not a specific finding for an SAH. Specific finding is xanthochromia. That's what you're looking out for. LP needs to be done after 12 hours of the onset of the headache. Do not do it before that. It will be waste. SAH. You have the diagnosis of SAH, you got a scan done, and it shows there is an subarachnoid hemorrhage. What you do next? What you do next is you involve the neurologist. Treatment is done. But in documentation, you need to always mention about one of these classifications at least. That is Hunt-Hess grading system or an World Federation of Neurological Surgeons. Why this classification is important? At presentation, what was the grading? Depending on that, the prognosis is set. For example, at presentation itself, the patient was comatose. The prognosis is very bad. Unlikely the patient will survive. For that particular reason, if you can grade it, it will be very much helpful for the intensivist to explain the prognosis and keep the relatives or keep the well-wishers understand what will be the prognosis and what to expect from this. So grade 1 in Hunt's classification is mild headaches they are having, or they will be remaining very much asymptomatic. You're picked up in a very early stage basically here. Moderate to severe headaches. Moderate to severe headaches, anyone is having, it is a grade 2. Sometimes there might be third cranial nerve, that is oculomotor palsy, might be present with it. In grade 3, the patient has low GCS. Sometimes focal neurological signs also might be seen. In grade 4, he's stupor. Stupor means he's not responding for verbal stimulus. Only for the painful stimulus, he's just localizing. This is the motor response, what we are basically looking out for. In comatose, basically he's posturing, either decerebrating or he's decorticating. That is the stage or grade 5 or the stage 5. There is one more classification known as World Federation of Neurological Surgeons, where grade 1 is GCS 15, grade 2 is GCS between 13 to 14, grade 3 along with the GCS between 13 to 14, there are some motor deficit is present. In grade 4, the GCS is 7 to 12, doesn't matter motor deficit is present or not. Grade 5, the GCS is between 3 to 6, doesn't matter motor deficit is present or not. How do you manage? For any emergency, you will manage with an airway, breathing, circulation, deformity as usual. You will involve the neurologist as soon as possible. This is the step 1 what you are doing whenever you are suspecting an SAH. Sorry, whenever you have a diagnosis of an SAH. Then there are two drugs which can be given in these patients. That is, one is nimodipine, another one is mannitol. Mannitol is mainly given to reduce the raised intracranial pressure. You want to reduce the raised intracranial pressure because of an SAH which has happened. Again, this drug is given on advice of a neurosurgeon. Okay, for example, neurosurgeon wants to take up this patient immediately and wants to do an coiling. He might not prefer you to give the mannitol at all. So it depends from patient to patient. So you need to take a call along with the neurosurgeons what needs to be done. Why do we give nimodipine? Nimodipine, we give it because SAH, whenever there is an SAH, there might be a cerebral vasospasm. What does it happen? Whenever there is a bleed is happening here, so this is the aneurysm, it started bleeding from here. So what happens is the proximal artery undergoes spasm so that there is no blood loss. The spasm will be so severe there will be no blood flowing at all. It can eventually lead into infarction. To prevent this reflex cerebral vasospasm, we usually give nimodipine 60 mg orally if he is able to take it. Otherwise, through an NG tube, that is nasogastric tube, we will be giving it. What are the other complications the patient might have? Increased risk of rebleeding, especially in first 24 hours, the risk of rebleeding will be very high. Hydrocephalus can develop, that is increased pressure in the ventricles can happen. Subarachnoid hemorrhage, any insult to the CNS can cause, any insult to the CNS can cause, not subarachnoid, I'm talking about SIADH, syndrome of inappropriate antidiuretic hormone can result. This will eventually result in low sodium levels. Whenever there is a stressful situation, SAH is a quite stressful situation. A lot of catecholamines gets released in your bloodstream. This can trigger an myocardial ischemia. A myocardial ischemia can trigger an pulmonary edema. So because of stressful situation, there is release of catecholamines causing myocardial ischemia, which will eventually might result in an pulmonary edema also. So these are the complications what you need to be aware of. Tension headaches. Tension headaches is a very common presentation. Usually they present with band-like kind of headache. Across the frontal, it will be bilateral. Across the frontal, what will be present? Intensity will be mild to moderate. No associated nausea and vomiting. No exaggerated by the physical activities. Basically, there are no red flags at all. So what you will do? You will just manage the pain. Simple paracetamol will be sufficient here. If it is not working, you can give an NSID and discharge them. Don't admit tension headaches, and it will become an unnecessary nuisance. Cluster headaches, very commonly asked in the very commonly asked in the exam. So you need to be aware of cluster headaches. Cluster headaches, typically the patient presents with pain around the eye or behind the eye. So the pain is around or behind the eye, what we'll be having. Associated with few other symptoms like watering from the eyes and inflammation of the conjunctiva of the eyes, watering from the nose, basically rhinorrhea. These are the symptoms which are usually associated with it. So around the eye or behind the eye, the pain is associated with the same side, watering of the eyes or injection of the conjunctiva. Usually it lasts in a cluster. It comes in a cluster of 30 to 120 minutes. And these clusters can last for up to several weeks, like 3-4 weeks it can last for. Remember that they are not associated with vomiting. In migraine, you see nausea and vomiting. It is not associated. In migraines, can be associated with an aura. Aura is not present in cluster headaches. What is the treatment? This is important, again, tested multiple times in the exam. The best one is to give the high flow oxygen. So this is the best treatment what you can give for someone who comes with a cluster headache. Just connect them to a non-breathing mask, give an high flow oxygen. Usually it works wonders. Then you will discharge him on an oxygen cylinder and make sure there is enough ambulatory oxygen available in the house for that patient. What if this is not available or if this is not practical in your emergency department, then you can treat it with an triptans. Triptans, the route is important. It is given subcutaneously or it can be given nasally. Remember that subcutaneously or nasally it is given. Normal painkillers like an paracetamol, NSAID, opioids, oral triptans. Oral I'm talking about. Here it is a subcutaneous or nasal we are talking about. Here it is oral triptans I'm talking about. These are not preferred in cluster headache. So do not give this in the cluster headache. Temporal arteritis. What does this mean? This is basically inflammation of the temporal artery. Temporal artery is in the temple region. So this patient will have pain in this region. That is the temple region what we'll be having. So if you palpate in this region, there is an inflamed artery. They will be having some amount of tenderness. As this inflamed artery has multiple branches to the scalp, so when you palpate the scalp also, they'll be having tenderness. How will they describe it? Whenever I comb my hairs, that will usually touch the scalp, resulting in pain. The pain becomes worse. Doctor, I have a headache, but whenever I comb, the pain becomes worse. Whenever I palpate or whenever I touch my temple, the pain becomes worse. Whenever I open my mouth, he opens his mouth, this artery gets stretched. So what will happen? Even the when he opens his mouth, the artery gets stretched, the pain becomes worse. All right. So this is the basic symptom or initial presentation what they are having. So opening the mouth or basically eating food. Whenever I eat food, the pain becomes worse. This is known as jaw claudication. So this is the classical initial presentation. Eventually, what will happen? Eventually, there will be involvement of the ophthalmic artery and the optic nerve gets injured, or basically there will be inflammation of the optic nerve. So these features are important for you to pick it up. So what will happen if there is an effect to an optic nerve? There will be afferent pupillary defect. The finding what you are having, it is known as relative afferent pupillary defect or simply known as RAPD. What is RAPD? So whenever you flash the light, the pupil should constrict. All right. So the pupil should constrict. So when you flash the light, the pupil will not constrict. That means there is an afferent pupillary defect what is present there. That is known as RAPD. That is a finding what you are having. Basically, afferent pupillary defect is the one what you need to remember. This is just a clinical sign. Red desaturation. Red desaturation means whenever you give this picture what I have put up here and ask him to name the colors, he'll say this is pink. This one also he'll say either pink or orange. He will not be able to pick up the red color. So either he'll tell it looks like an orange or it looks like an pink. He will not say it looks like an red at all. This is known as red desaturation. Eventually, there will be loss of vision. Remember, the temporal arteritis is usually associated with polymyalgia rheumatica. Polymyalgia rheumatica. So he will have myalgia and multiple regions. He'll be having pain and tenderness. Might be associated with some amount of weight loss. So if you ask him, a chronic history of myalgia usually will be present in a patient with an temporal arthritis. So past medical history, the important one what you need to concentrate is polymyalgia rheumatica. As it's an inflammatory disorder, getting inflammatory markers like ESR and CRP, usually it is preferred that you get both the inflammatory markers, ESR and CRP. If both are elevated, then it supports your diagnosis that much more. The definitive diagnosis is by doing an temporal artery biopsy, which is usually done by orofacial maxillosurgeons. It is done by, so you need to admit this patient to get it done. What you do in the emergency department is you are just suspecting. Whenever you are suspecting, you are starting them on a high dose of prednisone. Then you will be referring to the ophthalmologist and rheumatologist because it is an rheumatological disorder where it is associated with polymyalgia rheumatica. Ophthalmologist you are involving because this patient can lose their complete vision. So ophthalmologist specialist should also be involved here. Cerebral venous thrombus. It is an thrombus in a vein, basically. Most of the time, this thrombus is in superior sagittal sinus. This is the superior sagittal sinus what you are having. Thrombus is usually in this region. It usually continues as an interjugular vein, a major vein what you are having. So the thrombus most common site is superior sagittal sinus. What are the predisposing factors? No one, everyone will not have a clot in an cerebral venous. Usually there will be some of the risk factors. Whenever there is a risk factor, that is an indication to go ahead and get a CT scan done in the emergency department as an initial investigation. So someone is on an OCP. OCP means specifically we are talking about estrogen containing OCP. Not sometimes there are certain kind of OCPs where are it is just an progesterone. Progesterone only pills are available as an oral contraceptive pills. So you need to specifically see that it is an estrogen containing OCP what the patient is taking. A dehydration. Any reason might be there for a dehydration. Someone who is a pregnant. These are the basic risk factors what you need to remember from exam point of view. There are other risk factors also like coagulopathies, like polycythemia. So basically coagulopathies will predispose to thrombus formation. This thrombus can form anywhere in the body. Here it has formed in a cerebral venous thrombus. Dehydration, we have spoken about nephrotic syndrome. Usually they go into dehydration. Chronic inflammatory disorders like Behçet's disease or inflammatory bowel disease can lead to this one. Infections like meningitis, sinusitis, mastitis, basically infections in your head and surrounding structures might result in an cerebral venous thrombus. How do they present to the emergency department? Usually they present with an headache. Okay, this headache doesn't has a classical description like an essay. Basically, they present with an headache associated 40% of the time with seizures like activity, what you are seeing here. Sometimes there might be neurological deficit like an unilateral weakness might be present like hemiparesis, weakness of the lower limbs, sometimes aphasia, ataxia. So some neurological deficit might be present. Sometimes some cranial lesions also might be present. So classical presentation, how to suspect it? There is no very classical presentation. So whenever they want you to choose an cerebral venous thrombus, one of the risk factors usually will be mentioned in the stem of the question. So look out for the risk factors. If it is mentioned in the stem of the question, then pick it up. So look for whether the patient is dehydrated or on estrogen containing OCP pills, whether the patient is pregnant. Look out for this one. One more thing is postpartum is also an risk factor. Postpartum is also a risk factor for two reasons. In postpartum, you would have lost lot of blood. Okay, during delivery, there is loss of blood is present there. Again, recently she was pregnant also, so hypercoagulability state was there. Keeping those in mind, CVT becomes common. But someone who is pregnant, remember this point, someone who is pregnant presents to emergency department with an headache, always think of an preeclampsia first. Okay, eclampsia, preeclampsia and eclampsia is much more commoner than CVT. For that reason, always suspect an preeclampsia first. If the preeclampsia is ruled out, for example, the blood pressure is within the normal range and there is no proteinuria is there, then think of an CVT. CVT should be the second in line for you in the differential diagnosis in a pregnant woman who presents with an headache. First, we usually go ahead and get an CT brain done, CT plain brain done. You might see some signs like this. This is more to pick it up by an radiologist to see an to see an CVT. It is not always possible to pick it up in NCT brain. For a definitive diagnosis, it's always required to get an MRI venogram done and see which of the uh, sorry to see which of the sinuses which are involved. Most of the time, it is a superior sagittal sinus which is involved. You start with an anticoagulant, treat the underlying cause. If it is present, for example, patient is taking OCP, stop on the OCP pills, or the patient is dehydrated, hydrate the patient. Underlying cause, you need to treat it. If the patient had if the patient had epilepsy, then you treat it with anti-epileptic treatment. That means if the patient had an seizure, then give an anti-epileptic. Do not give it as in prophylactically. So anyone who has an CVT, do we give an anti-epileptic medication prophylactically? Answer is no. But anyone who is having an seizures and presented to the emergency department due to an CVT, do we give anti-epileptics? Yes, obviously you will give anti-epileptics at that point of time. Medication overuse headache. As the name suggests, he's taking multiple painkillers or a single painkiller for a very longer time. Then you call it as a medication overuse headache. If the patient is taking one of these drugs for minimum of 3 months, then you can consider this might be a medication overuse headache. Someone who is taking combination of drugs, for example, a paracetamol and NSAID and codeine. So the combination of drugs, two drugs is taking minimum for minimum of 10 days, then you can consider it as to be a medication overuse headache. Someone who is taking in paracetamol, aspirin, or NSAID either alone or in combination on 15 days per month or more. It might not be continuously he's taking, but he's taking almost 15 days in a month. He takes 1 day, it doesn't take 2 days. Then he takes 3 days, it doesn't take 1 day. In that way, if you count, if it comes up to 15 days in a month, he's taking any one of these painkillers like aspirin, paracetamol, or NSAID, still you can consider this as to be a medication overuse headache. What we do is we stop all the medications what he is taking. Okay, just stop abruptly. You're not gradually stopping it. You're just abruptly, you're stopping all the medications what he's taking. Then just discharge him, just recounsel him and reassure him that the headache will come down. It is because of the medication what you're taking. Do not worry and discharge him. Do not admit it will be unnecessary admission for these patients. Trigeminal neuralgia. So basically, there is something wrong with the trigeminal nerve. Something wrong means it might be an inflamed trigeminal nerve which becomes very sensitive. Okay, it is not inflammation to be more precise. The nerve is very sensitive here. Trigeminal nerve, the basic function of the trigeminal nerve is to pick up the sensation from your face. It has three main branches, the ophthalmic branch, the maxillary branch, and the mandibular branch. But they all basically pick up the sensation from your face. If there is trigeminal neuralgia, this nerve becomes very sensitive. So even for a small stimulus, while having an food itself, they can have severe pain. Someone touches this cheek, they can have in severe pain. Okay, this is a clinical diagnosis. Usually it will be unilateral, not on the both sides, might be associated with some amount of jaw stiffness might be there, some clicking sound might be present. So remember that jaw stiffness there in trigeminal, sorry, in temporal arteritis, I spoken about jaw claudication. Here I'm talking about jaw stiffness. There is a difference what is there. In both, I'm talking about jaw and jaw. Do not get confused. Whenever the jaw comes, it is not in temporal arteritis. It can be seen in trigeminal neuralgia also. It is a clinical diagnosis. No investigations is required. Usually, we start and treat with carbamazepine. There are various other drugs also available for trigeminal neuralgia, but first line of drug what we use is carbamazepine, not pregabalin or gabapentin. Those are the other drugs which are usually used for trigeminal neuralgia. Status epilepticus. What is status epilepticus? A seizure, that is a single seizure which is lasting for 30 minutes, that is more than 30 minutes if it's last, then we call it as a status epilepticus. If two or more seizures which are lasting without complete recovery in between the seizures, then also you call it as a status epilepticus. What do I mean by the second phrase? First phrase is a single seizure, he is having involuntary movements which is lasting more than 30 minutes, is a status epilepticus. What does the second phrase mean? Second phrase means he has a seizure which lasted for 5 minutes, the involuntary movements have stopped. He's in the post-ictal state. What is the post-ictal state? Usually there will be some amount of drowsiness, agitation will be there soon after the seizures, and slowly they'll gain back their complete consciousness. Usually it lasts for 5 to 10 minutes. Here what happens, while he is in post-ictal state, there is one more episode of seizures which might be lasting for 5 minutes. Again, he is in post-ictal state, but he has not recovered completely. Again, he has one more seizures. So if this totally, if it is more than 30 minutes, then again we call it as in status epilepticus because this patient has not recovered completely without recovery of consciousness in between the episodes, what we are talking about. So what are the causes for status epilepticus? Someone who is already a known case of epilepsy, most common causes for is drug withdrawal, or it might be poor compliance with the drugs what he's taking, or suddenly he stopped taking the drugs, or he is taking some like benzodiazepines and he has stopped taking it. Some changes in the therapy might have triggered the epilepsy what the patient is having. What are the other little bit rare causes can be? It can be an intercurrent illnesses like a meningitis, encephalitis, some metabolic disorders, especially electrolyte imbalances, co-ingestion of other drugs which might reduce the therapeutic index, or for example, an phenytoin, if you take an cytochrome P450 stimulator, then the efficacy or the effect of the phenytoin will come down drastically. In those conditions, these patients can have an status epilepticus. Someone who doesn't have an history of epilepsy at all, this is the first time he is throwing and seizures. In that time itself, he has a status epilepticus. Then think of a drug withdrawal syndrome, like he was taking benzodiazepines and suddenly has stopped, or barbiturates he has taken stopped, or an alcohol withdrawal seizures what he is having. Or there might be a structural brain injury because of a stroke, often bleed in the subarachnoid space, or because of an hypoxia. Or it might be because of an CNS infection like a meningitis, encephalitis, or an abscess. What you need to remember here is 30 minutes is the definition of status epilepticus. But the treatment of status epilepticus starts within 5 minutes. Why? If we wait for 30 minutes, that means there is increased amount of electrical activity is generated in the brains for 30 minutes. Your brain will get fried. For that reason, you need to intervene as soon as possible. Otherwise, the brain damage might be quite severe. So what we do is we once the seizure starts, you start the clock and then you start assessing the patients. What you'll do an ABCD assessment, start him on high flow oxygen, check his blood glucose level. Sometimes hypoglycemia might be the cause, especially in the children's you will be seeing it. The same thing what you'll be doing in the adults also. If the patient is hypoglycemic, you will treat. If you found out any underlying cause in this 5 minutes, you will treat the underlying cause. It's been 5 minutes till the seizures have not subsided. Then we start intervening. Why do we wait for this 5 minutes? We wait for this 5 minutes because 95% of the cases 95% of the cases of the seizures usually subsides in this 95, sorry, in this 5 minutes. Within 5 minutes, 95% of the seizures usually subsides. So we need not even intervene at all. If it's last more than 5 minutes, that means it's not gonna subside unless you intervene. That's why you want to go ahead and intervene. The first line of drug is giving benzodiazepine. Okay, most of the time when the patient is having a seizures acutely, you may not be able to get an IV line. In a child, it is preferred if you do not have an IV line to give an midazolam buccally. Okay, in an adult, you will be giving diazepam per rectally 0.5 mg per kg, what you'll be giving. If you have an IV line secured, both in adult and pediatric age group, the preferred drug is lorazepam. The pediatric dose you need to remember is 0.1 mg per kg, with the maximum what you can give is 4 mg. The adult dose is 4 mg. The adult dose is directly 4 mg itself. You have given the benzodiazepine, one of the benzodiazepines, for example, you have given lorazepam. You have waited for 10 minutes. After 10 minutes, that is 5 plus 10, it becomes 15 minutes since the onset of the seizures. So after 15 minutes of the onset of the seizures, if the patient is still seizing, you will give second dose of benzodiazepine. For example, if you are given lorazepam, continue giving lorazepam, one more dose, same dosing, 0.1 mg per kg in pediatric age group. In adult, it is 4 mg what you will be giving. In adult, there is one more choice, parahaldiate 0.4 ml per kg per rectally can be given, which has to be mixed with olive oil. Most of the time, it is not available in the emergency department to give it. You need to have an olive oil, you need to have parahaldiate, then mix it and give it. It takes more time. It may not be available. So most of the time, we end up giving another dose of benzodiazepine itself. You're given this, you're waited for 10 minutes, and now it has been 25 minutes since the onset of seizures. Still, the patient is actively seizing. That's when you will start giving second line of agents. There's three second line of agents. One is levetiracetam, second one is phenytoin, third one is the phenobarbital. Out of these three, the preferred one is levetiracetam. Why it is preferred one? The side effects are least. You can give it much more rapidly compared to the phenytoin and phenobarbital. For that reason, we give levetiracetam as a preferred drug. Phenytoin, we do not prefer to give it mainly because of its cardiac toxicity. It can cause arrhythmias. ECG monitoring is a must, and it should be a slow IV infusion because phenytoin usually blocks sodium channels in the cardiac muscle myocardium that triggers arrhythmias. Phenobarbital is an barbiturate which causes severe respiratory depression. Even apneas can happen. That's why it is not preferred compared to levetiracetam. So levetiracetam is the preferred drug. Same thing holds good in the adults also. There are no changes. You wait, you are given the second line of drug or you have started infusion for the second line of drugs. After 5 minutes, still the seizures have not subsided. That means you need to start thinking ahead. This patient might require a rapid sequential intubation. You call the anesthetics, or in a pediatric age group, you'll call the pediatric ICU and the anesthetics. In adults, you'll call the adult anesthetic and make sure they are available immediately. Then totally you have waited for 40 minutes since the onset of the seizures. Still it has not subsided. Then what you will be doing? Then you will be doing a rapid sequential intubation. The induction drug what you'll be using is the thiopentol. This is the preferred one. For some reason thiopentol is not available or it is contraindicated, then you can go ahead with propofol. If that is not there, ketamine, then that is not there, midazolam. So these are all have anti-epileptic effects. The best one is the thiopentol. Sodium is the best one. It is a barbiturate. It has an excellent anti-epileptic effect. That's why thiopentol is preferred over propofol or ketamine or midazolam. If that is not given in the option, choose propofol. If that is not given in the options, choose ketamine. If that is also not given in the option, choose midazolam in the same sequential order. The same thing holds good for adult also. You are not able to immediately do a rapid sequential intubation at 40 minutes for any reason. It might be because you do not have an equipment ready, or you might not have an pediatric anesthetic available, or you might not have an skilled, or there might be not equipments at all, or there might be not a skilled physician to intubate an pediatric age group. At that point of time, what can you do? You can give a second or third line of agent, you can give it. Which is the second line or the third line of agent which you can give? The one which you are not already given here. For example, if you're already given an levetiracetam, then you shouldn't be giving this drug. You will be giving either phenytoin or phenobarbital. If you're already given phenytoin, then you will be giving either levetiracetam or phenobarbital. The one which you are not given, you are giving that drug now while waiting for all the equipments and the personals available so that you can perform a rapid sequential intubation. Next thing what you need to remember here is most of the time these patients are already a known case of epilepsy they will be. Okay, they will be on certain drugs. For example, the patient might be on levetiracetam. So do not give levetiracetam itself, give another drug. If he's already on levetiracetam, give phenytoin. If he's already on phenobarbital, give either phenytoin or levetiracetam. Do not give phenytoin, do not give phenobarbital at all. Okay, you should give another drug what the patient already is on. Why? Because the patient is already on and he's having a status epilepticus. That means this drug is not effective. You can assume that the drug might not be effective. That's why you are giving another drug of choice. Most of the time when you get an venous or an arterial blood gas analysis done, there will be an acidosis. Both metabolic and respiratory components will be contributing for this acidosis what is present. Do not correct this acidosis by giving an bicarb because the acidosis itself has an anticonvulsant properties. That's why you are not treating this acidosis. Once the seizure subsides, give some fluids like a normal saline, you can give it, and usually this acidosis will disappear. This acidosis is mainly because of increased muscular activity, one, producing large amount of lactic acid. Next thing is respiratory components. Because he is actively seizing, his respiratory muscles are also involved. The respiration was not adequate. That's why the carbon dioxide was retained. Once seizures have subsided, the muscular activity has decreased and respiration is regained back. Then the carbon dioxide washout will be there and metabolism will occur at the normal rate and it will. So do not correct this acidosis. Correcting this acidosis, you will lose the anticonvulsant property. Acidosis has an anticonvulsant property. It might help to stop the epilepsy. What are the investigations? Mainly the investigations is done to see the underlying cause. Is it because of an hypoxia or electrolyte imbalances like hypomagnesemia, calcemia, hyponatremia, hypokalemia, or it is because of an infection like full blood count for the infections, lumbar puncture might be required for the infections, blood culture, CT brain might be required to see an abscess. ABG to see how bad was the seizures, basically to assess the severity of the acidosis what the patient is having. It might be because of a drug withdrawal or because of a certain drugs also. A sympathomimetic drug like an cocaine can trigger an epilepsy. If he's already on an anti-epileptic drugs, get an serum anti-epileptic drug levels done to assess and see whether the drug was effective or not, why it is not effective. To get an idea, this is mainly for the neurologist. What about if the patient presents with an first fit? How do you manage if the patient presents with an first episode of epilepsy and it has subsided and it is completely normal? That means the patient is not in post-ictal state. He has regained his complete consciousness, and this was the first episode of epilepsy. What you'll be doing? You do the investigations to see the underlying cause. Can it be an infection? Then get an urine analysis, chest X-ray, blood cultures. Can it be an electrolyte imbalance? Get calcium, magnesium, urine electrolytes. Get full blood count again to see for an infection. Blood glucose levels, can it be an hypoxia? Sometimes a VT and VF can mimic as seizures, but post-ictal drowsiness will be absent in that. The description usually is given by bystanders. They may not give you a clear history whether it was an proper post-ictal drowsiness was there or not there. They may not give a clear history. Then there might be some confusion. So getting an ECG done is also an important parameter. So anyone who presents with an first fit, that is the first time he ever had an seizure. When to get it? When to get an CT scan done? Here, I have not mentioned any imaging at all. You get the imaging only and only done in an unprovoked first seizure is if any of this following is present. That is, any new onset focal neurological deficit is there, any altered sensorium, any prolonged headache or fever this patient was having, any previous head injury recently he had, history of any immunocompromised cancer, HIV or suspected HIV is present. Anticoagulant use, any anticoagulants, it can be from warfarin to rivaroxaban to apixaban, any of these anticoagulants if he's taking. Previous history of stroke or neurological conditions, if is present, then you need to get it done. And this is a seizure which has happened in an elderly person who is more than 65 years age group is known as elderly. And if this seizure has happened in this elderly person, then you'll go ahead and get an CT scan done. What about a person who is already pre-diagnosed with an epilepsy, comes with an one more new episode of epilepsy? When do you get an CT scan done? These are the initial five things. The initial five things what you have discussed is the same thing. 1, 2, 3, 4, 5 is the same. This five parameters what you have discussed, the same thing what I have mentioned here. These last three are only specific for a patient who has an unprovoked first seizures. You have not found any underlying cause. You feel it is an idiopathic seizure what the patient is having. So what you will be doing, you're planning to discharge this patient. While discharging patient, make sure there is a responsible adult accompanying the patient for next 24 hours. Okay, and explain them how to pick up and seizures. This responsible adult should be able to pick up and seizures. When this involuntary movements happens, they should be able to pick it up. First aid advice on managing subsequent seizures. Basically, you need to place the patient in left lateral position so that there is no aspiration. Make sure there are no objects surrounding the patient so that he doesn't injure himself. Make sure the patient is in lying position. If he's on chair, place him down on the floor itself. Okay. Do not put anything in the mouth. These are the classical first aid advice what you need to give it. Driving advice also you need to give it. We'll be discussing this at the end of the class. All the driving advice at DVLS will be discussing at the end of the class. Appointment with an epileptic specialist will be given within the 2 weeks. So no imaging is done. Remember that first epilepsy imaging is not done unless one of these following is present. If present, then only you are doing an imaging. Before I go into the stroke, anyone has any questions? Yes, status epilepticus means it has to last more than 30 minutes. It might be a single seizure which is lasting for 30 minutes, or sorry, lasting for more than 30 minutes, or it might be multiple seizures without gaining full consciousness lasting for more than 30 minutes. Do we do an ECG in febrile fits in first episode? We're not, febrile fits is only for pediatric age group. What we have discussed here is only for the adults. In the pediatric age group, we will be talking about febrile seizures. Doctor, regarding the steps of management of status epilepticus, will follow the treatment according to the time of presentation in the ED. That is in gray area what you are having. I'll explain you. Prolonged headaches or fever duration. Prolonged headaches, and anyone who is having a fever is a fever. Prolonged headaches means he is having a history of fevers lasting for days together. It's not hours, it's days together. When to do an ECG in first phase? You as an emergency physician will never get an EEG done. EEG will not yield you anything. It is only for the neurologist. It is not an investigation to be done in the emergency department. So never get an EEG done. It is never available in the emergency department. So always EEG is a wrong answer. RAPD test is an basically a test done to see whether there is an efferent pupillary defect. Efferent, which nerve carries the efferent signals? It carried by an optic nerve. So basically, you're seeing the defect is in the optic nerve. That's all is required to be remembered. Family history of epilepsy can be a risk factor to order and CT scan. I didn't mention family history, so you're not ordering and family history. Okay. So what is mentioned here, you need to just follow that much. Do not overthink. Overthinking always will get the wrong answer in the examination. So you need to strictly stick to the guidelines what has been given here. So one of these questions was there is if someone presents to the ED, for example, after 15 minutes of seizures, what needs to be done? It is not mentioned in the guidelines what needs to be done if a patient comes after 15 minutes or after 30 minutes or after 5 minutes of seizures, because it mentions here as seizures have started. So after 15 minutes he has presented, do I need to directly jump here and start the second dose, or after 25 minutes he has presented, so I'll give levetiracetam? Do I need to do that? It is not mentioned in the entire guideline that what needs to be done. So that is a gray area. But what is usually practiced in practical, in practical point of way, what is practiced and what is expected you of in the exam? In exam, it is expected you is you will be giving one dose of benzodiazepine. Ideally, this benzodiazepine is given intravenously and lorazepam is given. We are at least giving one dose of intravenous lorazepam for any patient who comes with a seizure. Doesn't matter how long this patient is having a seizure, because lorazepam is an excellent drug to subside the epilepsy. Okay, subside the status epilepticus what the patient is having. So in those patients, we give an IV lorazepam. First drug. After that, depending on the time, it's been 1 hour. He presents to the emergency department. You're given lorazepam. It is not subsided. Wait for 5 minutes, not subsided. Then directly you can jump to rapid sequential intubation. So always give at least one dose of benzodiazepine. After giving one dose of benzodiazepine, wherever the time duration is, you can directly jump to that position in the algorithm. That is the recommendation from my side. That's what is being usually followed everywhere. I do not understand more than 5 minutes. It's what EPLI, what do you mean by that? You need to type completely. Now we are entering into an acute stroke. Acute stroke. What is the WHO definition? The WHO definition for an acute stroke is an focal neurological deficit. We are presuming to be in an vascular origin lasting for more than 24 hours, or within 24 hours itself, he has expired. That means he has dead. This is the classical definition of an stroke. Remember that it is 24 hours. So what we are doing, or whenever we intervene, we are suspecting it to be an stroke. Because if the patient completely recovers within a stroke, we call it as a transient ischemic attack, not an stroke. So whenever we are suspecting an stroke, we are intervening. There is a difference. So for that particular reason, we do NIHS scoring is done. Okay, I'll be talking about more in this. So it is a vascular version. So vascular means it can be a clot which has formed in the artery. Okay, so a thrombus, emboli, or a venous thrombus, or a carotid artery dissection. So something is wrong, and so that the blood supply to that particular organ is not going. Here, the organ is a brain. There is not adequate blood supply because something is wrong with the blood vessel. Or there is a rupture of the blood vessels, basically bleeding. So two important is it's an ischemic stroke where blood supply is not there at all, or the vessel has ruptured, resulting in a hemorrhage inside the brain. These are the two important differentiating factors. This important differentiating, or the two different causes, have completely different treatment. So basically what you need to remember, this is known as circle of Willis. I'm sure that you must have read it for your primary. So two vertebral arteries of the left and the right side join together to form an basilar artery. Basilar artery basically gives branch to an posterior cerebral artery. This much is known as posterior circulation. It's important, it is known as posterior circulation. Okay, I will be talking about more of this in coming up slides. So remember, this much is known as posterior circulation. Anterior circulation is basically internal carotid artery gives away a middle cerebral artery and an anterior cerebral artery. So internal carotid artery gives two branches. One is anterior cerebral artery, another one is middle cerebral artery. Anterior cerebral artery are interconnected at anterior communicating artery. That's where usually aneurysms are commonly seen, which is the commonest cause for SAH, what you'll be having. This much is known as anterior circulation. All right. Anterior circulation and the posterior circulation are joined together by posterior communicating artery. This is the posterior communicating what you are having. This joins the anterior circulation with the posterior circulation. Important thing what you need to remember is in the anterior circulation, that's where we do thrombectomy, mechanical thrombectomy. Mechanical thrombectomy is done only in the anterior circulation, not in the posterior circulation. So let us see the distribution. What part of the brain is supplied by which artery? First one, we'll see in the middle cerebral artery, which is a branch of an internal artery. It basically supplies this pink part, what you are seeing here. All right. So this pink part is basically the lateral part of the brain, what it is supplied by. Lateral part of the cortex, what is supplied by. So lateral part of the brain usually coordinates with your face, hand, and upper limb. Very less neurons are projecting from here to your lower limbs. Okay, so basically there will be weakness of the upper limb, face, or main weaknesses what you'll be seeing in the middle cerebral artery. Next thing what you need to remember here is your left side of the brain represents your right side of the body. Right side of the brain represents the left side of the body. So whenever there is a stroke, for example, on the left side, so the weakness will be on the contralateral side. That means the opposite side. That means on the right side. So the weakness is seen on the right side. Face and arms weaknesses are much greater compared to that of the limbs because it doesn't represent the limbs much. Opposite side, again, there will be sensory deficit. Yes, the patient will be looking towards the lesion as if he is pointing and seeing there is the defect what is there or there is the stroke what is present. Okay, if the dominant hemisphere is involved, in 99% of the human, dominant hemisphere is left side. Okay, even in a left-handed person, the dominant hemisphere is left side itself. It's not the right side, it's the left side itself. If the dominant hemisphere is involved, he will be having an expressive dysphagia. That means he'll understand what you're telling. But when he's telling to you, he's struggling to tell. He's not getting the words, or he's having a slurred speech. Usually he's not getting the words. What is your name? He knows what is his name, but he's not, he understood what the question was. You are asking what is his name. He knows what is his name, but he's not able to express it back to you. That is known as expressive dysphasia. If the non-dominant hemisphere is involved, neglect or inattention will be there. Neglect. One part of the body he will be neglecting. That means one part of the face he'll not be washing, one part of the face he'll not be brushing one part of the face at all. Okay. So, for example, one part of the face he might be hairs, one part of the scalp he'll be combing, another part of the scalp he'll not be combing because he's not giving, he's neglecting that part. He feels that part doesn't belong to him. That is known as neglect. Anterior cerebral artery. Anterior cerebral artery supplies the middle part and the frontal part. Frontal and the middle region. This is all the middle region what you are seeing. So the middle region, what you can see here is mainly supplies the legs. So whenever there is a weakness, legs are much more involved whenever there is an anterior cerebral artery involved, and it will be a contralateral. Same thing holds good for the sensory. It is a contralateral deficit what you will be having. Frontal lobe is important for your behavior. So disinhibition and altered sensoriums can be present. If there is a left-sided lesion, that means the left side, the dominant hemisphere is involved. Akinetic mutism and transcortical motor aphasia might be present. That is non-fluent aphasia with greatly reduced spontaneous speech. He has a repetition, he can do it. So, for example, if you ask him what is his name, he'll say John. So it is not fluent. He is able to say, but he takes time to say. Okay, it's a non-fluent aphasia. But if you repeatedly ask the same question, he can repeat it. Can you repeat your name? John, 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 John. Then he can repeat it properly. So repetition remains fine. Once he says the word, he can repeat it multiple times without any slurring or without any loss of fluency. But initially, when you ask the question, there will be loss of fluency. This is known as transcortical motor aphasia, which is seen because of anterior cerebral artery involvement, if the dominant hemisphere is involved. What about the posterior cerebral artery is involved? Posterior cerebral artery is formed by a basilar artery. Okay, basilar artery divides into left and right posterior cerebral arteries. Whenever the posterior cerebral artery is involved, the cortex, the occipital region is involved. Usually it is involves the visual region. So visual cortex is gone. If visual cortex is gone, contralateral homonymous hemianopsia is present. Along with there is an macular sparing. That is important. Macular sparing is present. Why macular sparing is present? Macular sparing means the central vision will be normal. Why this patient has having central vision? Along with this contralateral hemianopsia, this much vision will be fine. Along with the central vision on the opposite side also will be fine. So central vision, there will be no loss. Only loss of this, like a donut, half donut loss will be on one side. Another half donut loss will be on the other side. Why this macular sparing is present? Because macula has a dual arterial supply. One is from posterior cerebral artery, another one is from an MCA, middle cerebral artery. So the pathology is in the posterior cerebral artery. There is no pathology in the middle cerebral artery. So that will be supplying it. So the macular vision will be intact. Sometimes memory also might be affected in an posterior cerebral artery stroke. Now we are going into an vertebrobasilar artery. Vertebrobasilar artery basically supplies your stem. What is brainstem? Brainstem basically constitutes midbrain, pons, and medulla. Okay, and it also constitutes the cerebellar region. Cerebellar region will result in cerebellar signs like dysdiadochokinesia or loss of balance, which can be tested by Romberg sign, or dysmetria can be present. Finger nose test you can do it. Heel shin test can you do it. The various cerebellar signs what you can do it. It is also required for balancing. So vertigo this patient might be having. Some amount of slurring of the pitch. Dysarthria might be present. Visual field defects like diplopia can be present. A syncope can be there. All your cranial nerves, not all, most of your cranial nerves originates, or the nucleus of the cranial nerves will be present either in the midbrain, pons, or medulla. So same-sided cranial nerve deficits can be seen. Opposite side motor deficits are seen. Opposite side motor deficits are seen because the corticospinal tract crosses at the level of spinal cord, and the brain stem. So it has already crossed by the time it enters the brain stem. That's why the motor deficit is always seen on the contralateral side. Cranial nerves, nucleus is involved. So ipsilateral, the same side cranial nerves will be involved or be affected. Few syndromes you need to be aware of in the stroke. That is Weber syndrome. What is Weber syndrome? Weber syndrome is midbrain stroke. This is the midbrain stroke. In midbrain, there is the third cranial nerve which is present. Third cranial nerve nucleus will be involved, which will result in the eye positioning, classical eye positioning, outwards, downwards and outwards. The classical eye positioning in the third cranial nerve involvement will be present. Okay. This is supplied by the branches of the posterior cerebral artery. Collateral motor weakness can be there. The favorite one to be tested in the exam is the lateral medullary syndrome. You need to be aware of both. Next time they might ask you on medial medullary syndrome also. So be aware of. So medulla, what is medulla? This is the medulla what you are having here. Okay, medulla. If the lateral part of the medulla, this is the lateral part. If this part of the medulla is involved in the stroke, then it is known as lateral medullary syndrome. This part of the brain is supplied by PICA. PICA stands for posterior inferior cerebral artery. Okay, middle part of the medulla, if it's involved, then it is known as medial medullary syndrome. This is supplied by vertebral artery as well as anterior spinal artery. What are the structures which are present in middle here? A 12th cranial nerve, corticospinal tract, and the dorsal column. Okay, this is what you need to remember. Because corticospinal tract is present, contralateral, the opposite side motor deficit will be there because this carries the motor function. Dorsal column, we are already aware, we have learned this in the major trauma that it carries proprioception and vibration sensation will be lost again on the opposite side. Same side cranial nerve, same side the deficit will be there. This is the 12th cranial nerve, also known as hypoglossal nerve. The tongue usually when you ask them to protrude it, it will be deviating towards the side of the lesion, the same side of the lesion what you'll be having. Okay, that is basically what you need to remember for medial medullary syndrome. That is important. This is what you need to remember for medial medullary syndrome. What about lateral medullary syndrome? Lateral medullary syndrome, what are the structures which are the cranial nerve nucleuses will be present? Fifth cranial nerve, eighth, ninth, and 10th cranial nerve. 5, 8, 9, 10. 8, 9, 10 is in the same sequence. 5 is the additional one you need to remember. If you can remember which are the cranial nerve nucleuses are present, what are the deficit, what you're suspecting is easier too. So fifth cranial nerve is a trigeminal nerve. So loss of sensation over the face on the same side. Eighth cranial nerve is vestibulocochlear nerve. So some hearing will be lost along with mainly it is required for balancing. If balancing is lost, you will have vertigo. If vertigo is present, you'll start vomiting. Glossopharyngeal and vagus nerve are basically required for you to swallow. So there will be some swallowing difficulties and some difficulty in speaking when ninth and 10th cranial nerves are involved. Along with it, there is a sympathetic fibers which are involved. Sympathetic fiber involvement results in Horner syndrome. Horner syndrome is an triad what usually the patients will have. Pinpoint pupils or the meiosis what the patient will be having. At the same side, the patient will be having some amount of ptosis. Also, the patient will be having anhidrosis. Anhidrosis means that that part of the face will be completely dry. Meiosis means small pupil. Drooping of the upper eyelid is known as ptosis. Spinothalamic tract is involved. There it was dorsal column in the medial medullary syndrome. Here it is a spinothalamic tract. Spinothalamic tract carries pain and temperature. So contralateral loss of pain and temperature. Horner syndrome, remember it is an ipsilateral, same side. Okay, all the cranial nerves along with the sympathetic fibers all are on the same side. It will affect only the tracts like corticospinal tract, dorsal column, and spinothalamic tract. Only spinothalamic tracts comes on the lateral side. Medial side, you have corticospinal and the dorsal column. All are contralateral. Do not forget. Remember the artery which supplies it. It supplies the posterior inferior cerebellar artery. Simply, you can remember it as an PICA. Okay, short form is PICA. It is a branch of basilar artery. Now a patient present, we know different strokes and we know different arteries which are involved. A patient has presented to the emergency department with a stroke you're suspecting. What we do initially, we do an Rosas scoring. This is the scoring which is preferred in the emergency department. Again, very important, multiple times tested in the examination. So if there is an asymmetrical facial weakness, you get 1 point. Asymmetrical arm weakness, 1 point. That means right arm weakness is much more than compared to the left side. So it should be asymmetrical. It should not be symmetrical. If it's symmetrical, you shouldn't be thinking of stroke. Again, asymmetrical leg weakness is present, gets 1 point. Speech disturbance. Speech disturbance, it can be completely aphasic, not able to speak at all, or it might be difficulty in speaking, or it might be slurred speech. Everything comes in speech disturbance, gets 1 point. Visual field defects gets 1 point. Any loss of consciousness or syncope, -1. Seizures-like activity, -1. So stroke is unlikely if the score is 0 or less than 0. If it is 1, also stroke is most likely. Once you suspect and stroke, what is the initial investigation what you'll be getting it done? Initial investigation is CT plane plus CT contrast with an angiography. Okay, CT contrast angiography and a CT plane is the latest recommendations to get it done both together, because most of the emergency departments have capability of getting an thrombectomy done. What is thrombectomy? Thrombectomy is a catheter which is passed, as you are seeing in this picture, and they basically pass the catheter through the clot and drill it. What you're seeing here, drilling is happening here, and they capture all the minute particles and suction it out. This is the treatment of choice nowadays, and it's been extensively done in the emergency departments in the UK. Okay, not in emergency, it has to be shifted to the cath lab, and it has to be done by an interventional neurosurgeon or by an interventional radiologist usually does it. Okay, so this is the investigation of choice what you are getting. Minimum is CT plane. For example, your hospital for some odd reason doesn't do thrombectomy, then at least CT brain plane you get it done. We usually get an CT brain plane done mainly to rule out. To rule out what? To rule out and bleed. If you rule out and bleed, it is an infarct. If it's an infarct, then you can treat the patient. That is the investigation what you're doing. At the same point of time, you need to do NIHS scoring. NIHS scoring is an extensive scoring. They do not expect you to remember all the scoring, but it is important to know when do you call it as a mild stroke. You call it as a mild stroke if the NIHS score is less than 5. You call it as a severe stroke if the NIHS score is more than 25. If the NIHS score is less than 5, usually thrombolysis or thrombectomy is not preferred. Why thrombolysis or thrombectomy is not preferred in these cases? Because the NHS score is very low. That means we are expecting this patient to improve completely, and it will be an TIA most of the time. So we are suspecting this patient to be an TIA. That's why we are not doing an thrombolysis, that is giving an clot buster IV drug, or we are not doing a mechanical thrombectomy as shown here in the picture. If it's a severe stroke, is suggested by an NIHS score of more than 25 also, we usually do not do an thrombolysis or an thrombectomy. Why? If you do an thrombolysis or thrombectomy, there will be edema, so grossly edema will be there, it can cause uncal herniation and the patient can basically be brain dead. For that reason, it is not advised in a severe stroke. The prognosis is bad if you do an thrombolysis or thrombectomy. Also, it basically worsens the prognosis. That's why it is not recommended. So what is the treatment what you're giving for an infarct? So CT scan you have done, your rule out and hemorrhage, what you'll be doing. Everyone gets an aspirin, 300 mg what you are giving it. Orally it is preferred. If he's not able to swallow because swallow reflex is gone, gag reflex is gone, he might aspirate, you are worried about it. Put an NG tube and give it, or give it per rectally. But you are giving an aspirin here. It is as important as you give it in a myocardial infarction. Here also in a stroke, which is an infarct, you are giving aspirin. Thrombolysis. Thrombolysis to be done within 4.5 hours, that is 4.5 hours since the onset. And if there is an 4.5 hours and you have ruled out an intracranial hemorrhage. The dosing, you need not remember. If you can remember, it's very good. The dosing what is given is for what? Altiplase. Altiplase is the preferred thrombolytic agent what is being used. What are the contraindications for thrombolysis? Okay, you cannot always use in thrombolysis. What are the contraindication? It is an wake up stroke what you are having. Seizures at onset itself, it's present. Clinical presentation is suggestive of an SAH. So SAH causes a focal neurological deficit rather than a stroke, then you are not doing it. If low platelets, that means less than 1 lakh, it is present. Arterial puncture or non-compressible site or an LP is done within 7 days. Any GI bleed or an urinary tract bleed in the last 3 weeks if it is present. any head injury or a stroke or intracranial surgeries for last 3 months. Previous intracranial hemorrhage, doesn't matter when it is, or a previous brain tumor or known case of brain tumor or AV malformation in the brain or any aneurysm in the brain, it is a known case, then you are not thrombolizing. If the diastolic blood pressure at the initial presentation itself is more than 140, then you are not thrombolizing. If the diastolic pressure at the presentation is, if the systolic blood pressure at the presentation is 180 or the diastolic blood pressure at the presentation is 105 to 140 in this range, if it is, what can you do? You need to bring down this blood pressure. Okay. Once the blood pressure is reduced to less than 180 and less than 105, if it is reduced to this range, okay, less than 180, systolic by diastolic should be less than 105. How do you reduce it? Reduce it by giving labetalol. If you can achieve this one, then you can go ahead and do an thrombolysis. But absolute contraindication for thrombolysis when the blood pressure is, diastolic blood pressure is more than 140, which is very, very, very rarely seen. When do you do an thrombectomy? Thrombectomy, I have showed you already procedure. When do you do an thrombectomy? Remember that intravenous thrombolysis, if indicated, you'll start. Addition to that, you are doing an thrombectomy. It is not an alternative to intravenous thrombolysis. It is an addition to the intravenous thrombolysis, what you are doing. Okay. You try to do it as soon as possible, preferably within 6 hours of onset of symptoms in an acute stroke patient. And on imaging, it should be confirmed that it is the proximal artery which is involved. That's why we are getting an CT angiography done. Okay. What about MRI scan angiography? It is given here, but most of the time MRI takes longer time and it is not readily available. For that particular reason, MRI angiography is not very commonly used. But if the centers have an have an protocol in place to use an MRI angiography, you can use it. But most of the time, it is the CT angiography which is done. Right? Is the proximal. There is one more thing I have mentioned here, anterior circulation, not for the posterior circulation. It's only for the anterior circulation you're doing an thrombolysis. Only 6 hours. Can we do it beyond 6 hours? Yes, you can do it up to 24 hours, including the wake-up strokes can be done because of this. When do we do it? What is the indication here? You need to go and talk to the radiologist and ask him, is the brain is the brain salvageable? That means, is these neurons are not at dead? If I do an thrombolysis, will this neurons will be saved? This call will be given by radiologist. Yes, brain is still salvageable. Go ahead and do an thrombectomy. This call should be given by the radiologist. So you'll go and discuss with the radiologist if it is beyond 6 hours. Hypertensive emergency, as already told you here, is the hypertensive emergency here. We usually treat it with labetalol, again, tested twice in previous diets. Treatment for hemorrhagic stroke. Hemorrhagic stroke, what can you do in the emergency department? We are not giving any of this thrombolysis or thrombolytic agent because it will bleed more. So yeah, completely opposite treatment what you are having. We tend to reduce the blood pressure. The more the pressure is, the more the bleeding is. But there is an indication when to reduce it. It should satisfy all these parameters. If the patient has presented within 6 hours of the onset of the symptoms and the systolic blood pressure is in this range, then you give the drugs to reduce. Maximum what you can reduce is 60 millimeters of mercury. Okay. And your target is to bring it down below 140 over the time. If the presentation is after 6 hours, if the systolic blood pressure is more than what is mentioned here, that is more than 220, then you will decide case by case over the bedside. Because if the systolic blood pressure is more than 220, you're thinking whether it is an Cushing's reflex what the patient is having because of raised intracranial pressure. Do I need to drastically reduce the blood pressure or maintain a map of 80 here? Those calls clinically bedside you need to receive for any papilledema is there, any on the scan, any signs of raised ICP is present. Depending on that, you will take a call what next to be given discussing with neurosurgeons. Do not lower blood pressure in what conditions? If the GCS is less than 6, do not lower it. If there is a structural cause for the bleed, for example, bleeding from a tumor, AV malformation, aneurysm, do not reduce it. Neurosurgeons have decided to evacuate the hematoma which is present early. They are immediately taking up this case in the operation theater and planning to evacuate. Or it is bleed is so massive that the prognosis is bad. The neurosurgeon says there is no point in operating. I'm not operating. It is for the palliative care. If it's a palliative care, you reducing the blood pressure doesn't matter. Whenever the patient goes into the palliative care, basically what you're doing, comfort, not treating the cause or not trying to cure the patient. We're making sure the patient is comfortable. Transient ischemic attack, where the neurological deficit completely resolves within 24 hours. He goes back to his he goes back to his normal self, goes back to his baseline. Do not do any CT scan. For that matter, do not do any imaging in the emergency department. Any imaging in the emergency department is not advised. What is advised is you refer to the neurologist within 24 hours and get an MRI scan done within 24 hours, not immediately, within 24 hours. So basically what we do is we refer to the neurologist. Neurologist will make sure that he gets an MRI scan done and he sees him within the 24 hours. Start them on aspirin. If endarterectomy is considered, then you're doing an carotid imaging. Again, it is more for the neurologist and the neurosurgeons rather than for an emergency physician. Before I enter into the strokes, I'll take up questions and answer your questions. Aspirin used protective post aspirin, you're using very baby aspirins. Okay, baby aspirins cannot cause an medication overdose. It doesn't fit in. You're taking 75 mg. So that doesn't come as a medication overdose headaches. And aspirin shouldn't be stopped in an ACS for any reason. What is akinetic mutism? He is not able to articulate. If CT scan is normal, can we directly thrombolyze? Yes, you can do an thrombolysis. That's what you're doing it. That's what I meant by it. So basically, you're directly going ahead and thrombolizing the patient. Okay, you're basically doing the CT scan to rule out if there is a bleed. If there is no bleed, you're directly going ahead and thrombolizing the patient. You need not have any finding of infarction at all. You're just doing the CT scan to rule out the bleed. Is it needed to exclude malignant MCA? I don't know what is MCA and what is malignant you're talking about. By doing an MRI diffusion, I don't know what you're talking about. Okay, you need to be very clear. Do not write any short forms. Again, MRI, we do not do. We are not depending on the MRI's findings. As I keep on repeatedly telling you guys, we do not do. Most of the time, MRI scan is not available. It is time consuming. You're wasting time. Okay, each minute lost, there are thousands, if not millions of neurons which will die in and stroke. That's why each minute matters in a stroke. Time is very precious in stroke patients. Motor weaknesses. Motor weaknesses might be because of an upper motor neuron involvement, or it might be because of an lower motor neuron involvement, or it might be somewhere in neuromuscular junction. Upper motor neuron is basically a neuron which is coming right from your brain in your spinal cord. That is an upper motor neuron, UMN. From your spinal cord, it is going to the muscle. This neuron is known as lower motor. There is a communication between the neuron and the muscle that is known as neuromuscular junction, or something wrong in the muscle itself. For example, Dickinson's muscular dystrophy, neuromuscular junction, myasthenia gravis, another one, botulinum toxin, which is important, tested previously in the exam. Lower motor neurons is GB syndrome or subacute combined degeneration of the cords. What do you need to be aware of? Upper motor, already we have learned about like a stroke or a tumor. What do you need to be aware of? First one we are seeing is an subacute combined degeneration of the spinal cord, nothing but a lower motor neuron which is involved here. They classically presents within triad. Okay, whenever you stimulate the soul, there is an extension of the great toe. This is known as Babinski's sign. Babinski's sign is present if there is an extension which is seen in subacute combined degeneration of the spinal cord. Knee jerks will be, that is, knee reflex will be quite brisk. Ankle reflex will be absent. Treatment here is by giving vitamin B12. Why? This is the vitamin B12 deficiency which causes subacute combined degeneration of the spinal cord. Very commonly seen in vegetarians. Why it is commonly seen in vegetarians? Because most of the vitamin B12 comes from the meat. In our diet, most of the vitamin B12 is from the meat. Syringomyelia. Syringomyelia usually causes cape-like loss of pain and temperature. Pain and temperature, we already know that it is carried by spinothalamic tract. So spinothalamic tract, bilateral side of the bilateral spinothalamic tracts are involved. That is left side as well as the right side spinothalamic tracts are involved. So what happens here? What is seringo? Seringo means it's a cystic cavity. This is a cystic cavity which is enlarging. And this cystic cavity which enlarges and specially causes compression over the spinal thalamic tract. So bilateral loss of pain and temperature is the classical presentation of syringomyelia. What you'll be doing, you'll be just referring. Guillain-Barré syndrome, again, very important from exam point of view, previously multiple times tested, including in the last TAT. So what happens? What is the pathophysiology of Guillain-Barré syndrome? Usually, these persons will have acute gastroenteritis caused by Campylobacter. Your body, to fight against the Campylobacter, your B cells will produce antibodies. These antibodies will fight against the Campylobacter. But at the same time, these antibodies also go and attack the myelin sheath of your nephrons. That's why a Guillain-Barré syndrome occurs, because of the destruction of the myelin sheath of the lower motor neurons. This will result in bilateral weaknesses of the lower limbs. Okay, it starts from the lower side. So it is ascending. Foot is involved, ankle is involved, calf muscles are involved, knee is involved. So it is ascending upwards. Slowly, it will be ascending upwards. So motor weakness is the classical presentation what this patient will be having. On examination, if you check the reflexes, usually the reflexes will be lost. Okay, the reflexes will be hyporeflexia or completely lost of reflexes will be present here. It is a clinical diagnosis. No investigations is required whatsoever. It's a clinical diagnosis. Doing a nerve conduction study doesn't label that this is Guillain-Barré syndrome. It's a clinical diagnosis. Ascending paralysis, what this patient is having. That is the clinical paralysis within past medical history of an gastroenteritis, most likely caused by Campylobacter. Then you have a classical history having, so easily clinically you can diagnose it as an GP syndrome. What we do in the emergency department here is we record the lung function by doing an FVC, forced vital capacity. Why is it important to document the forced vital capacity in the emergency department? Yes, come with the weakness of the lower limbs. Why am I worried about the lung function here? Because this weakness can ascend upwards and involve the diaphragm. If it involves the diaphragm, he can go into respiratory arrest at any point of time. Okay, so diaphragm involvement will not happen all of a sudden, it happens slowly. So how to know whether the diaphragm is involving or not? If we come to know the diaphragm is involving, what is the advantage? The advantage is you can prophylactically intubate the patient if you know the diaphragm is getting involved. How to know diaphragm is getting involved? To see the forced vital capacity. Why it is important to document in the emergency department? If you document the forced vital capacity in the emergency department, this will be the baseline. So every day the intensivist will record the forced vital capacity and see and compare it with the baseline what you're having. If it is reducing, then he will think and plan for an prophylactic intubation. Thus, the importance of documenting and forced vital capacity. What is the treatment of choice? Treatment of choice is intravenous immunoglobulins. It is expensive. If someone is not affordable, then plasma exchange you can offer him. But the preferred one is always intravenous immunoglobulins. It is a quite expensive one, but in NHS, everything is free and they give it free of cost. So intravenous immunoglobulins is the choice. A variant of Guillain-Barré syndrome is known as Miller-Fisher syndrome, usually presents with ophthalmoplegia. Ophthalmoplegia means extraocular muscles are paralyzed. So eye movements will be very minimal eye movements will be having, if not nil eye movements. Ataxia, balancing will be lost and reflexes will be lost. This is the classical triad what usually they present with Miller-Fisher syndrome. Botulism. What is botulinism or what happens here? It is an Clostridium botulinum infection affects the neuromuscular junction. Another neuromuscular junction what we'll be studying today is myasthenia gravis. Botulinism is also important because it has appeared in the last that can appear for you also in the exam. Initial symptoms are very non-specific GI symptoms like nausea, vomiting, diarrhea, abdominal cramps. It is non-specific. It will not be helpful. Just you need to remember that initially GI symptoms will be presenting. Classically, they presents with an descending symmetrical paralysis, which is exactly opposite to GBS. GBS is ascending. This is descending. Both are symmetrical. Both are motor weaknesses what are involved. Especially it is a neuromuscular junction. So it is motor only what is involved. There is absolutely no sensory involvement at all, what you need to remember. So no sensory involvement at all. As it is coming from up to down, that means cranial nerves will be involved. The muscles controlled by the cranial nerves, that is the muscles of your face, facial expression muscles, the swallowing muscles, that is basically vagal nerve and the glossopharyngeal nerve. Those muscles will be involved. Because of that, the patient will be having dysarthria, dysphagia, diplopia. Those kinds of features will be initial. Pupils will be dilated and non-reactive to the light also can be present. Reflexes will be usually diminished. Very much similar here. What is happening exactly opposite of GPS? What you need to remember, GPS is ascending, this is descending. Both are symmetrical. What are the muscles? This is descending. So you're thinking from the head. So what are the facial expression muscles will be involved? Extraocular muscles will be involved. Your swallowing muscles, your tongue is also a muscle that will be involved because it's a neuromuscular. As it is a neuromuscular, absolutely no sensory deficits will be there. In infants, how do you make it out? A floppy kid. You hold them, there is no tone at all. It is a completely floppy kid what you are having. That is a classical presentation of botulism in an infant. What do you need to look out for? How do you treat it? With an antitoxin. This treatment is preferred if the kid is more than 1 year. Less than 1 year, it is not preferred because it might cause allergic reaction and serum sickness, so it is not preferred. Symptomatic treatment, obviously, you will be giving depending on what are the symptoms the patient is having. Accordingly, symptomatic treatment will be given. Antitoxin is the treatment of choice in more than 1 year age group. Less than 1 year, it is not preferred. Hydrocephalus. Hydrocephalus is basically increased pressure in the ventricles. Increased pressure in the ventricles might be because the CSF is not getting reabsorbed. Okay. It is not adequately getting reabsorbed, but the communication between the ventricles, that is between the lateral ventricles and all your ventricles through the aqueduct of humor, all those things are happening. Communication is fine, but reabsorption of the CSF is just not happening. That might cause raised pressure in the ventricles. Non-communicating, there is some obstruction between the ventricles to the third ventricle to the fourth ventricle. Somewhere it is obstructed. If it's obstructed, there is no flow. CSF gets accumulated. CSF getting accumulated, more and more CSF will cause more and more pressure. Normal pressure hydrocephalus is a variant of communicating hydrocephalus. Okay, exact pathophysiology still now it is not known, but it classically presents with a triad of dementia where the person cannot remember things. Loss of balance will be there. Along with there will be certain amount of urinary incontinence. This is the classical presentation of an hydrocephalus. Sorry, this is the classical presentation of a normal pressure hydrocephalus, not all the hydrocephalus, normal pressure hydrocephalus. A patient who is already known case of hydrocephalus, how do they treat it? Or how do neurosurgeons usually treat an hydrocephalus? They usually drain it. Drain the CSF, what is present in the ventricles. Because either it is not getting absorbed or there is an obstruction. You want to drain it. They will drain it through the peritoneal cavity most of the time. Okay. This is known as ventriculoperitoneal stent. Sometimes to the lumbar region, they might drain it. Sometimes to the lumbar region, that is known as lumbar peritoneal region. Whenever they are having an VP shunt, we call it, or they are having an LP stent, VLP stent, we call it, ventricular peritoneal stent, or an ventricular lumbar peritoneal stent. One of these stents are present. They come to the emergency department with severe headache, raised ICP symptoms. Whenever there is a raised ICP, think of there might be a blockage or there might be some infection is present. How to know if there is a blockage because of an infection or something has gone wrong and it has blocked? You get a series of X-rays done. Okay, shunt series X-rays, you will tell the radiographer, they will be aware of it. They'll get a series of X-rays done and you will show it to the neurosurgeons and they will take a call what needs to be done. Idiopathic intracranial hypertension. So we do not know why there is increased intracranial pressure, intracranial hypertension. Why it is happening, we do not know. It is also known as benign intracranial hypertension. It is also known as pseudocerebric. Very commonly seen in women in their 20s and 30s. And the pain is worse in the morning and the evening time. In between, they feel quite comfortable. And it is worse on lying down and relieved on standing up also. Some amount of visual defects can be seen. Sixth cranial nerve palsy, that is horizontal diplopia, can be present in them. Sixth cranial nerve supplies the lateral rectus. So lateral rectus, whenever they are seeing towards the lesion, they will be having an diplopia. That is horizontal diplopia. It is towards the lesion. Whenever they see towards the lesion, they will have an diplopia. This is known as horizontal diplopia caused by sixth cranial nerve because it supplies the lateral rectus. This patient might also have an papilledema on examination because of increase in intracranial pressure. If you grossly see, this is all symptoms of an increased intracranial pressure, along with cranial nerve involvement of sixth and visual field defects because increase in intracranial pressure, your occipital lobe might be involved. Investigations is a CT scan or MRI, LP. All investigations are usually normal because it is an idiopathic. You do an LP, the opening pressure might be normal. CT scan will be normal. MRI will be normal. So all investigations will be normal. This is a clinical diagnosis, but you need to rule out other causes for raised ICP. What you will be doing? So you will be giving acetazolamide. Okay, carbonic anhydrous. Basically, you need to reduce the pressure, so you're giving an acetazolamide. If that doesn't work, you can do repeated LPs. When do we do an surgical decompression? Whenever there are eye symptoms are present, then surgical decompression will be required. A part of the skull will be done, a craniotomy will be done, and do an surgical decompression. This is usually reserved for patients who have eye symptoms. Okay, but usually, initially, we start with an acetazolamide. Again, these are all chronic managements. Acetazolamide, if you can remember, that should be sufficient. Erb's palsy, if your brachial plexus C5 and C6 roots are involved, then you call it as an Erb's palsy. Clums's palsy, if the roots of C8 and T1 of the brachial plexus are involved, known as Clums's palsy. Clums's palsy is very on the lower side. The apex of the any lesions over the apex of the lung is present can cause Clums's palsy like an Panco's tumor. Okay, and usually the hand will be in this picture. The Vetus tip hand. This is known as Vetus tip hand, very typically seen in Erb's palsy. But most of the time, C5, 6 is either should be any trauma or it is in childbirth which is seen. Otherwise, it's a rare entity to be presenting to the emergency department. Most of the time, it is a childbirth injury. Now, facial nerve palsy we'll be looking at. Facial nerve palsy can be an upper motor or an lower motor. Mainly, we are talking about an lower motor facial nerve palsy. How to differentiate between an upper motor and a lower motor facial nerve palsy? For that, you need to be aware of little bit of anatomy. Okay, the upper part of the face till here, what you am here, it has bilateral representation in the brain. So it is representing over the right side and the left side of the brain. So if there is a stroke on the right side, left side will take over and the sensations and the functionality of that part will be intact. But the lower half doesn't have bilateral representation in the brain. So if the stroke is there, the upper part will be intact, the lower part will be affected. Stroke is where the lesion is in the brain. This is an upper motor neuron lesion. So in an upper motor neuron lesion, only the lower half of the face will be affected. If it is the facial nerve which is affected or the nucleus of the facial nerve which is affected, which can be seen in brainstem strokes, especially if the pons are involved because the facial nerve comes in the pons. If those are involved, the entire half of the face will be gone because the facial nerve of this side supplies the entire half. So entire half will be gone. That's how you differentiate it. So clinically, what are the signs and symptoms what you'll be looking out for? You ask the patient to raise the eyebrows up. There will be wrinkling, which will be seen in upper motor neuron. It will be intact. Okay, you will ask the patient to close the eyelids really tightly. If they're not able to open it, that means it is intact. But the naso, sorry, sorry, the facial deviation is to the opposite side. To the normal side, there is some facial deviation is present and some muscle weakness is present, especially if the patient is not able to close the lips and blow the air. Then you are thinking of an element palsy. No, the patient is not able to wrinkle the forehead and raising the eyebrows and not able to tightly close the eyelids. Then you are thinking of an lower motor facial nerve palsy. Lower motor facial nerve palsy can be because of various causes. Most common causes idiopathic, we do not know. Idiopathic is known as Bell's palsy. Sometimes it might be because of an infection. For example, a middle ear infection or viral infection. Sometimes might be a parotid gland enlargement, a malignancy of parotid gland, or an inflammation of the parotid gland. Sometimes it might be some neurological conditions like diabetic neuropathy or GB syndrome can predispose to it. Sometimes a viral infection like an Lyme's disease, where classically you see and target lesion, can be because of this. Vascular insufficiency, that is vestibulobasilar artery insufficiency, can have it. The important one, another one, what you need to remember is Ramsay-Hunt syndrome. What is Ramsay-Hunt syndrome? It's basically facial nerve involvement, that is lower motor facial nerve involvement is present in this patient caused by herpes virus. Why do I say an herpes virus? In Ramsay-Hunt syndrome, in the ear, you will be visualizing the vesicles. What you're seeing here, these are known as vesicles. Okay. Here, the treatment changes. We add up an acyclovir also because it is a herpes infection. So because the entire half of the face is involved, he's not able to close his upper eyelid properly. Eye care is important for this patient. So in treatment, eye care. So in lubricating drops, you need to prescribe them at the night, ask them to tape the eye so that the eyelid remains closed and the eye doesn't get dry. If the eye gets dried, it will have a friction with the upper lid, can cause corneal ulcerations. That's why lubricating the eye is important. What is Ramsay-Hunt syndrome? As I told you, in Ramsay-Hunt syndrome, with the high doses of steroid, you will be adding up an acyclovir. That is important. Just a Bell's palsy you are having. It is an idiopathic just in Bell's palsy. It is a lower motor lesion what you are having. Then you treat it with steroids. Steroids plus eye care, what we have discussed previously. That is what is required. This is for adults, not in the pediatric age group. In the pediatric age group, what is required? In the pediatric age group, nothing is required. You'll just ask them to follow up with the 3 weeks. Do you need to remember the, sorry, do you need to remember the dosing of steroids? No, absolutely not. The dosing is not required, but it will be definitely helpful for your practice. You may not be searching on the internet for your practice. It will definitely be helpful. Okay, giving 50 mg daily for 10 days is an easier one to remember. Okay, this is what is been given in your Oxford Handbook of Emergency Department. This is another protocol also. If you want, you can remember for your practice. Transverse myelitis, transverse entire spinal cord, transverse from this entire diameter of the spinal cord is involved. Inflammation, myelitis is nothing but inflammation of what? Myelin sheath. Myelin sheath means the covering of your neurons are involved. How do they present to the emergency department? Usually certain amount of pain will be there, these patients. Okay, like viral infection or vaccine might be there, but most of the time it is associated with multiple sclerosis. Underlying multiple sclerosis or undiagnosed multiple sclerosis might be present there. Okay, they will be having motor, sensory, autonomic disturbances over days to weeks. So sensory, motor, and autonomic disturbances might be present for days usually. The main important factor you need to remember is that reflexes are exaggerated. They are increased. A brisk reflex, what you'll be seeing. Contrary to botulinism, what we learned, contrary to the GB syndrome, where reflexes are absent. Areflexia, what we'll be seeing, or decreased reflexes. Here, the reflexes are exaggerated. Okay, brisk reflexes, what you'll be seeing. And usually urinary and bowel incontinence will be seen. MRI scan is required for a diagnosis of transverse myelitis. Corticosteroids, because it's an inflammation, what has happened. Sometimes even a plasma exchange will be required. The advice needs to be taken from the neurologist about what treatment, only steroids or plasma exchange also required. You need to involve the neurologist for that. Tapes dorsalis. Tapes dorsalis is a complication of syphilis. Syphilis, we treated with penicillin. So the treatment here is penicillin. Tapes dorsalis classically presents with these two symptoms, which will be helpful to differentiate. One is known as Argyll-Robertson's pupil. Another one is posterior column signs. Posterior column is nothing but dorsal column. Dorsal column propulsion and vibration sensors are lost. If that is lost, the patient will end up having wide based and high stepping gait he'll be having. Proprioception, he cannot gauge properly. Proprioception is lost. For that reason, wide based and high stepping gait he'll assume. What is Argyll-Robertson's pupil? When you flash the light on the eye, there will be no constriction of the pupil. Generally, it will be slightly constricted, like around 2 mm or 2.5 mm it will be. But when you flash the light, it will not constrict at all. But when you try to accommodate, that means you'll ask the patient to look far and suddenly you bring an object nearer to him and ask him to look at. Like you have bought a pen and you ask him to look at. Accommodation, usually the eyes get converged and pupils get constricted. Here the pupils will get constricted. But when you just throw the light, the pupils will not get constricted. So this is known as Argyll-Robertson's pupil. Okay, this is a classical sign which is seen in Tapes dorsalis. along with posterior column signs, that is wide-based gaze and high stepping gait, what will be presenting. What is myasthenia gravis? Myasthenia gravis, like botulinism, is a neuromuscular junction disorder. So neuron is present here. This is the neuron what you are having here. And this is the muscle what you are having. Both communicate usually with an acetylcholine. Acetylcholine is basically an hormone with which they usually communicate with. So there are nicotinic receptors. These are acetylcholine receptors, nicotinic receptors over the muscle there. So it releases, the neuron releases this acetylcholine and communicates with the muscle. These nicotinic receptors are much less in a patient who has an myasthenia gravis. For that reason, what will happen? Initially, when you wake up in the day and carry out activities, you'll be able to carry out the activities. Later on in the day, this receptors will get saturated. There are only few receptors. They get saturated. Doesn't have normal number of receptors there. So they will start developing the weaknesses. The most initial weakness which they develop is the ptosis. Ptosis is the initial presentation. Usually they will be saying, doctor, in the morning when I get up, I feel completely fine. Over the day, then I feel completely exhausted. I'm not able to open my eyelids at all. I cannot carry out any regular activities. This is the classical presentation of an myasthenia gravis. That is the diagnosis of myasthenia gravis. The one who is already diagnosed with myasthenia gravis can come to the emergency department with either myasthenia crisis or cholinergic crisis. What is myasthenia crisis? You're not giving adequate treatment. What is cholinergic crisis? You're giving over treatment. So what is myasthenia crisis is basically you're not giving enough treatment at all. What you do in myasthenia gravis, you try to stimulate this nicotinic receptors by giving the drugs. Okay, as much as possible, you'll be stimulating it. You're not giving adequate drugs. That's when myasthenia crisis is seen. You're giving too much of drugs so that this all receptors get saturated. That is the extreme other end. How to differentiate? Both presentation will be same. Usually, I'm having breathing difficulty because already diaphragm is also involved here at the neuromuscular junction, and they might even present with an severe difficulty where ptosis is present, muscle weaknesses are present, even breathing difficulty can be present. How to differentiate in the emergency department? In the emergency department, you give edrophonium. If you give edrophonium, which is a treatment of myasthenia gravis, usually all the functionality will improve. He'll start improving and visible improvement will be seen, drastic improvement will be seen. But in cholinergic, what will happen? Over medication, you're giving more medication, the symptoms can worsen. The symptoms can worsen so much so that there might be respiratory paralysis and the patient can go apnea. So have standby anesthetic to intubate this patient at any point of time. So that's how you will implicate here, which is overdose and which is not there. And clinically, you will involve then and increase the anticholinergic drugs, anticholinergic drugs in an myasthenia gravis because it's under treatment. Over medications here, so atropine, what you'll be giving if respiratory paralysis is occurs, then you might have to ventilate. While testing if there is an respiratory paralysis, then you need to ventilate these patients. Multiple sclerosis. What happens in multiple sclerosis? Multiple sclerosis, there is demyelination of the neurons which happens. Why it happens? It's not known. Okay, till now we are not able to figure out why demyelination happens in multiple sclerosis. And it happens scatteredly. Okay, for example, it happens in one part of frontal part, left side frontal, next it will be right side occipital, and for few months it will be completely asymptomatic, then somewhere else. So how do you suspect in multiple sclerosis? You suspect in multiple sclerosis when this patient has different neurological deficit which cannot be explained by a single anatomical site. For example, if this is a brain, what you are considering, if something is wrong here, there are few features which can come because of this. Okay, basically this is right side, left side. So you will have a right side weakness, what you'll be having. This patient comes, he has a left-sided weakness, also in right-sided, left-sided upper limb weakness, right-sided lower limb weakness, along with the slurring of the speech and some gait disturbances suggestive of and some brainstem involvement. So multiple anatomical regions of the brain is involved, cannot be explained with single anatomical region. Then suspect of an multiple sclerosis, more commonly seen usually in females in an younger age group. Most of the time, they present with the first symptom of an optic neuritis. Okay, optic neuritis, basically inflammation of the optic nerve, which we have already learned. We will be having a Marcus gun pupil, which is nothing but RAPD, related to afferent pupillary defect, what will be present there. Blurring of the vision, compromised color vision will be there, which we have already learned here. There will be no vivid red color. He can appreciate it. And eye pain will be there because there isn't some amount of inflammation. MRI scan is required. You just refer to the neurologist. Nothing much can be done in the emergency department. That's what you need to remember. One of you was asking RAPD. You want to remember what is related to afferent pupillary pupillary defect, RAPD. First, we'll see what is pupillary defect. There is no pupillary reflex. When you flash the light on the eye, there should be constriction of the pupil. If there is no constriction of the pupil when you flash the light on the eye, then afferent pupillary defect, what we are suspecting. Okay. Whenever you flash the light on a normal eye, both the eyes constrict because it has bilateral representation. Okay, because it has bilateral representation, that's why both the eyes constrict. That's what you need to remember. That is important. Both the eyes constrict normally. They constrict. The affected eye also constrict normally. But when you flash after this constriction, then you go back and flash the light on the affected light, the pupils will start dilating. It will not constrict, it will start dilating. Both the eyes starts dilating. That means relative this is known as RAPD basically. Okay. In very simple term, optic nerve is involved. That's all. Okay. RAPD is more of a clinical examination and pick it up and rule out where exactly the pathology is there. For us, just flash the light. There is no pupillary constriction. You flash on the other side, both the pupils are constricted. Then you come back and flash the light here. It is not constricting, it is dilating. Then it is known as RAPD, relative afferent pupillary defect. DVLA guidelines, now we are coming up to. There are various DVLA guidelines which are there extensively there. Okay, this is only the gist what I have put up. There are more than this. The DVLA guidelines are present. Okay, driver vehicle licensing authorities guidelines. For example, if someone has an epilepsy, they cannot drive for 1 year. And if they are driving a heavy motor vehicle like a bus or lorry, they cannot drive for 10 years. And they need to notify the DVLA, notify for the DVLA. Any unprovoked seizures is there for 6 months and 5 months is present. Stroke, multiple TIA, they have different things. Hypoglycemia awareness and no awareness. If there is awareness, no restriction is there. If there is no awareness, then the license is revoked for both the persons. Cough syncope, first episode 6 months, more than one episode 12 months. Here, even one episode for a heavy motor vehicle is 12 months, more than one episode is 5 years. Next thing is unexplained syncope. Unexplained syncope, you revoke the license for 6 months and they must notify for the TVLA. It becomes 12 months if it is an heavy motor vehicle. These are the minimum things what I usually advise for the students to go, because most of the questions have appeared either from a syncope or from an cough syncope it has appeared, hypoglycemia, stroke, epilepsy. Okay, I'll put up a link. This is not a complete list. There are few blanks are still remaining here which needs to be completed. There is an official government website of in UK. You can go through it. I'll put up the link today itself on the Telegram group. You can go through it if you're interested to know everything what is present about the DVLA guidelines and you're good at memorizing the things. Please do memorize, because one question can appear from these guidelines. Okay, I am not good at memorizing, so I told this is the minimum thing at least, and you can check your luck. If something comes in this, then you can answer in the exam. Before going the recall questions, I'll take up your questions, then we will go into the recall questions. If CT scan is normal, can we directly thrombolize? Yes, you can directly thrombolize. Is it intended to exclude malignant MCA? I'm not sure. Large MCA artery infarction, is it contraindication to give thrombolytics? It's not the large MCA artery infarction what you need to look out for. It is the NIHS score. If the NIHS score is 25, you are clinically, you as an emergency physician, you are clinically looking for the criteria. What the radiologist looks for, it's only for the radiologist, not for you. Clinically, that's why I told you NIHS score of and more than 25. What does it indicate? That means a major artery is involved. That means more proximal end of MCA or a proximal end of ACA is involved. If you thrombolize this patient, the prognosis will be bad. It will be catastrophic to catastrophic to thrombolize this patients.
Excuse me, sir. Please, how we can, according to their criteria, we can count zero, less than zero? I didn't understand this point, please.
If there is an loss of consciousness, there is a syncope or loss of consciousness, you give it as -1. Okay, there is one more thing. If the patient had an seizures, you give it as -1. For example, he had a facial weakness, you give it 1. But he had a loss of consciousness as well as seizures. So it will become total if you add up this one, and this one, if you add up, it will become -1. So it is not an stroke, what you need to presume. Okay, that's the zero score or -1, or it can be even -2. These are the scores what we are expecting. For example, he had a facial weakness. That's why unilateral facial weakness is there. You're given +1. Along with it, he had a loss of consciousness, -1. So the total score becomes 0. So unlikely this to be a stroke. That's what the Rose's criteria says. So you have an understanding there?
Yes, thank you. Appreciate.
Okay. Any other doubts anyone has? Please do ask if you have a genuine doubt. Happy to clear it. All right, we'll go further ahead. We have a 40 years old female present to the emergency department with a right-sided retrobulbar pain. Since morning, it is associated with an watering of the eyes and nasal discharge. So with this itself, we already know the diagnosis of this is basically a cluster headache what the patient is having. There have been no similar complaints in the past, and her vital parameters are as follows. So vital parameters are completely fine. We are not worried about, and we know it is a cluster headache. It is a clinical diagnosis what I am having. They're asking what is the next best step? Treatment. What treatment you will be going? High flow oxygen is the preferred treatment what you'll be giving in this individuals. A 13 years old boy came in with the dad to the emergency department complaining of a severe pain on the left side. The mom couldn't get the boy to the emergency department as the mom was busy with her work. Headache is associated with the watering of the eyes. So headache, watering of the eyes is present. There is no significant past medical history. All the vital parameters are fine. What is the best initial investigation? Severe headache over the right side, left side, they are saying. They are not saying whether it is a around the eye retrobulbar. Doesn't matter. It is associated with the watering of the eye. Still, you need to think of an cluster headache. So when you are thinking of a still and cluster headache, that's when you will go ahead and choose again high flow oxygen is the preferred one. Triptans can be given, but their second line of drugs, it is not given orally. It is given intranasally. It is preferred one. A 33 years old first week of postmortem present to the MS department with one episode of and seizures and lasted for approximately a minute's time, drowsiness for 15 to 20 minutes. The patient has been having gradual onset of headache with unilateral upper limb weakness for 2 to 3 weeks. On examination, these are the things what you are having. What are we suspecting? There is an headache which is present, which is there for chronically. Now the patient has presented with two parameters which are presented with. One is with the seizures, what is there. Another thing is the patient is postpartum. Keeping the mind in postpartum is a risk factor for CVT. And usually at CVT, 40% of the time they will have an seizures and there is a headache. So putting all this together, the patient is having an CVT, cerebral venous thrombus. A 26 years old male felt he would fall off the chair because of the spinning sensation, which he describes as a room rotation, and it is associated with stiffness. Neck stiffness is associated. The patient attended his karate classes as usual last night. The patient is not known to have any medical disorders, is not on any regular medications. The vital parameters seem to be fine. What is the most likely diagnosis? Neck stiffness. He is involved in an contact sport. Okay, it's a contact sport what is there. Neck stiffness and vertigo, which are these signs? These are the basically suggestive of an posterior circulation stroke. Posterior circulation is basically consist of an basilar artery, vertebral artery, and PCA, posterior communicating artery. So what are we thinking about posterior circulation stroke? So we are either thinking about vertebral, basilar, PCA. So we are thinking about a basilar artery dissection to be most appropriate here because all these signs are suggestive of an posterior circulation. So the right answer is basilar artery dissection. Basilar artery infarct also can be there, which is not given, or it can be in vertebral artery dissection also can be present. The wife, the wife found her husband, 46 years old, collapsed in the house when she returned from the shopping complex. This is the basic history what they presented with. But he had been recently visited to the GP with vertigo and headache. The wife says his vertigo persists even after taking medications prescribed by the GP. Has no known comorbidities. On examination, the GCS is 10/15. Observation shows an respiratory rate of 20, 94 grossly looks normal, the vital parameters what we are having here. So what are we thinking? Someone who is collapsed at home, we have various differential diagnoses, including carbon monoxide poisoning. Okay, carbon monoxide poisoning, something is burning in the house, someone has collapsed in the house, is a very common thing what we'll be having. But the other thing what you need to remember is since 2 days he's been having vertigo and headache, and the wife says it is not been improved. So this vertigo and headache is not a normal vertigo and headache. That means it's not a peripheral vertigo. It is a central vertigo which GP has missed it, eventually has resulted in full blown stroke. That's why it is an it is a stroke what did the patient had. That's why we call it as an basilar artery stroke what we are suspecting here. So remember, posterior artery circulation is a basilar artery. Vertigo is a sign of posterior circulation. He had vertigo previously. Now he has collapsed. That means it has become a full-blown stroke. These questions have appeared multiple times, including in September 24 diet. So remember, this question might appear for you guys also. A 35 years old lady developed a sudden onset of occipital headache associated with multiple episodes of vomiting. She had her hair washed in a saloon yesterday and she had no similar headaches in the past. Her medications includes OCP pills. On examination, the patient is drowsy, easily arousable. The vital parameters are given here. What's the most likely diagnosis? Remember that whenever they mention this, hair washed in a saloon, that means this, they usually hyperextend the neck on the sink and wash the hairs. This entire head weight will come on the back of the neck, which usually in an elderly person's, here young person is there, but in most of the time it is an elderly person, will cause injury to the basilar artery or the vertebral artery. Always suspect whenever they give an saloon, in spite they are given an OCP pills, do not pick up an CVT here. Always pick up an vertebral or basilar artery dissection. Here, vertebral artery dissection is given, pick that up. It's a classical history, multiple times seen in the emergency department, hence multiple times tested in the exam. A 13 years old male child was brought to the ED by paramedics. Mom mentioned that the kid started seizing while he was at home. He is a known case of seizures on sodium valproate, and dad has given midazolam once. Paramedics administered one dose of midazolam orally. On arrival to the emergency department, the patient is still seizing. The nurse has secured the IV line and started him on high flow oxygen and placed the kid in left lateral position. What is the most appropriate next step? Most of the time, in the stem of the question, they'll not mention the time. When did it start? It's been how many minutes since the onset of the seizures? That till now in the exams, they have not mentioned at all. Okay, third one is wrong. Both of you, what your answer, third one is wrong here. Okay, time they'll not usually mention at all most of the time. So what we'll be doing is whenever they have not mentioned the time, go in a sequential order. What is the sequential order? First, what we'll be doing is give one dose of benzodiazepine. Second is second dose of benzodiazepine, what you're giving. Third is second line of drugs. Second line of drugs for us is levetiracetam. Here, one dose of benzodiazepine is given by the dad. Another dose of benzodiazepine is given by the paramedics here. So you're already done this. So you're here. Levetiracetam is the right answer here. So the correct answer here is the second one. A 8 years old boy was brought to the ED by worried mom. He complains of an facial weakness, difficulty in closing the eyes on the same side. So it is suggestive of what? LMN, seventh cranial nerve palsy, which is also known as facial nerve palsy or and Bell's palsy. Parents are really worried that the kid might be having a stroke. On examination, no limbs weakness are noted and no lesions over the ear. No lesions over the ear will rule out and Ramsey-Hunt syndrome. The kid is hemodynamically stable. An image of the face is shown below. What is the most likely diagnosis or the treatment? Treatment basically for the Bell's palsy, they are asking in the pediatric age group. In the pediatric age group, what we do is we just ask them to follow up after 21 days, that is 3 weeks with the GP. No steroids are given. Remember, no steroids are given in the pediatric age group. A 80 years old female was brought by her family to the ED. She says she sees people in her bedroom that no one else can see. She is a known case of hypertension, macular degeneration. Observations are as follows. They are completely fine. Her cognitive examination was normal, including her complete neurological examination. What is the most likely diagnosis here? This is a difficult one, but they have repeated the same question multiple times. So if it comes in the exam, it will be exactly the same thing. You need to pick up the same thing. The right answer here is Charles Bonnet syndrome. What is Charles Bonnet syndrome? In Charles Bonnet, what happens? People who are having macular degeneration, there will be loss of vision will be there. Because of loss of vision will be there, eventually they'll start hallucinating. Okay. So this is the hallucination what the person is having. This is basically an psychophysical visual disturbance. It is a physical visual disturbance what the patient is having. This starts hallucinating. This is known as Charles Bonnet syndrome, seen only in persons who are having macular degeneration. A 39 years old male was brought to the ED in an ambulance with a history of two back-to-back seizures. Okay, each one lasted for 5 minutes. There has been no further episode since 30 minutes. He is not known to have any medical disorders and is not on any of the prescribed medications. He is hemodynamically stable, but the GCS is low. This is important. GCS is low. What is the most appropriate initial management in this patient? What you will be doing for this patient? Yes, intubation is the right answer, because always remember that whenever we are answering the questions, we are always going in an ABCDE manner. Okay, ABCDE, this is stable, then only we go for specific treatment. Unless specific treatment you can give it in the breathing itself, then that's a different story. What is important here? The seizures have already subsided, which lasted for subsided, but it's been 30 minutes. So it cannot be considered as a post-ictal drowsiness. If it lasts for a very long time, it's better you intubate because the reflexes will be lost. He can aspirate at any point of time. For that reason, prophylactic intubation is required. So GCS of anything less than 9 is always an indication for intubation, what you need to remember. An elderly man came in the ambulance with a 2 hours history of weakness and reduced sensation in the right arm and right leg. He has expressive dysphagia and facial asymmetry. There is no LOC, syncope, visual disturbances, seizure-like activities, past medical history are involved, and vital parameters are within normal limit. They are just asking Rose's criteria. So one point goes here, another point goes here, here dysphagia, another point, and this is the fourth point. So it is on Rose's score, it is 4. A 45 years old male complains of right upper limb weakness, which he noticed while he was having breakfast. He was worried he was having a stroke, hence he immediately came to emergency department. By the time he arrived, the weakness has completely resolved. It lasted for 30 minutes. Presently, he has no weaknesses and he is hemodynamically stable. What discharge advice, what is the DVLA advice, what is the driving advice they are asking here? So what is the diagnosis here? He has completely recovered and got back to his baseline, so it is an TIA. In TIA, you advise them to not to drive for 1 month. They are given 1 year also, but whenever they want to test you on a heavy motor vehicle, they will mention it. He is a bus driver, he is a lorry driver, they will specifically mention it. If they have not specifically mentioned it, always consider it as a light motor vehicle like a car or a motorcycle. A young female came to the ED with complaints of bilateral lower limb weakness since last 1 to 2 days. She gives a recent history of gastroenteritis for which she has taken no on-the-counter drugs and has completely recovered. On examination, the vital parameters are as follows, which are completely stable. Bilateral motor weakness in the lower limbs with minimal sensory loss and loss of reflexes. This goes classically in favor of GBS, Guillain-Barré syndrome. So right answer is Guillain-Barré syndrome. Basically, here they are asking 34 years old, presented to the ED with numbness, complaints of numbness over the right side of the face since he woke up. There is no history in the past medical history. He has no other comorbidities. Vital seems to be fine. Image of the face is given. Here you can see one side, the wrinkling of the face is completely lost, and there is facial deviation is present on the normal side. This is suggestive of an Bell's palsy. Okay, Bell's palsy, that is seventh cranial nerve palsy is present. How do you treat it? Give it steroids. Usually 50 mg, what you will prescribe it for 7 days. BD, what will be prescribing it. Here, the right answer will be discharged with oral steroids. No CT scan is required. No IV steroids also required. Per oral steroids are more than enough. Refer to the neurologist, not required. Reassure and discharge. No, you need to prescribe steroids. A young male was brought to the ED by his colleagues while he was working on the computer. He suddenly started having jerky movements on all his four limbs associated with uprolling of the eyes and urinary incontinence. This has never happened before. Currently, the patient is asymptomatic and hemodynamically stable. Routine blood investigations, including electrolytes, are within the normal range. According to DVLA, he is not allowed to drive for what? So, what exactly he had? He had an first unprovoked seizures. For this, what is the recommendation? 6 months is the recommendation. Again, we are considering it as a light motor vehicle because uh, no further history is given here. A 22 years old female presented to the ED with annoying lower limb weaknesses since past last few days, which gets worse while with exercise. So worst with exercise. She denies taking any illicit drugs and has no comorbidities. She feels exhausted after a whole day's work. Observation shows a respiratory rate completely fine, all the vital parameters. So, what are we thinking about? After exercise, she's becoming worse. Or basically, after working out or carrying out some activities, her weakness gets worse and worse and worse. GPS doesn't present like this ascending weakness. Metastatic disease, 22 years old, we are not suspecting. Compressive myelopathy, again, not spinal tumors, also way too far fetched. It is a myasthenia gravis, clear cut diagnosis of a myasthenia gravis. A 49 years old female presents to the ED with a severe headache and a pain score of 8 out of 10. You receive the patient in resuscitation bay, an IV line has been secured, and you give the intravenous morphine for the patient. Vital parameters are given here, which shows blood pressure to be on the higher side. CT scan shows intracranial bleed. Which one of the following is true? Maintain a mean arterial pressure of more than 100. No, it is not recommended. It is wrong. Maintain a systolic blood pressure of less than 140. What is the recommendation? Again, wrong. Reduce the blood pressure not more than 60 millimeters of mercury per hour. Yes, it is the right one. Lepitilol, if GCS is 6, no, doesn't matter what is the GCS. You can give it at any GCS. Lepitilol is the drug of choice to give it in this condition. Intubate. GCS is 14. You need not intubate. You intubate when the GCS is less than 9. So the right answer here is the option 3. A 40 years old male accompanied by his wife came to the emergency department with a right-sided upper limb weakness since last 2 hours. No similar complaints in the past. Is not known to have any medical disorders. On examination is stable. The speech was not coherent. Neglect is present. Neglect is present when the wife is stood on the left side. What is the Rogers score here? Rogers score is 1 for this one and 1 for the speech what I am having here and 1 for the motor weakness what is present. Is neglect in the Rogers score? No, neglect is not in the Rogers score. So the score here is 2. You need to remember the score here is 2, not 3. Neglect is not in the Rogers score. Neglect is usually used to calculate the NIHS score. A 34 years old male presented with an ascending weakness of the bilateral lower limbs. A couple of days back, he had a diarrhea which he has not sought any medical help. He has no past medical history. On examination, his lower limbs power is only 2 by 5 with loss of reflexes. Clinically, you diagnose it as an GB syndrome. Which one of the following is most sensitive predictor of respiratory involvement? The only one thing what we learned is FVC. Okay, forced vital capacity. This is needs to be recorded recorded in the emergency department itself for the base level. An elderly female presents with a severe occipital headache says she never felt this severe pain in her entire life. The case of she is a known case of hypertension, and the vital parameters are kind of fine. You get a CT diagnosis, and this is done. Once the patient is back from the CT diagnosis, her GCS has fallen down to 8. What is the next best step? What are we seeing on the CT scan here is the classical frog appearance, what we call it. It is a diagnosis of an SAH. Here, the GCS, you can see it has drastically fallen down from 15 to 8. What we do, we intubate the patient first rather than doing anything else. So, intubation should be the right answer here. If you do not intubate, there might be a respiratory compromise. He might arrest. For that reason, intubation should be the first thing, especially when the GCS is low. Tongue fall can be there, resulting in respiratory compromise. Intubate the patient because of the low GCS. Then you will start with one of these drugs here. What needs to be done? Because we are doing an A, B, C, D, E assessment here. Intubation should come way up here. A 35 years old lady with develops a sudden onset of occipital headache associated with multiple episodes of vomiting. She has washed her hair in the saloon yesterday. She had no similar headaches in the past. She includes OCP. Examination is given. Drowsy but erasable. What is the best investigation they are asking? So what are we suspecting first? We need to know. Then we can decide what is the best investigation we'll be doing for this patient. What are we suspecting? We are suspecting an vertebral artery dissection here because saloon is given. Doesn't matter OCP is given. Saloon is given. For vertebral artery dissection, you need to see how you see it by getting an angiography done. So CT angiography is the right answer here. A dissection cannot be seen on a plain CT scan. Venogram is mainly for the veins. CT brain plane and CT contrast also may not exaggerate the arteries, may not be helpful with the diagnosis. A 70 years old female presents to the ED with an upper right upper right upper and lower limb weakness. Right upper and left lower limb. It is right here and it is left here. She also complains of left ocular vision loss. Observation shows which are completely normal. CT scan has been normal. What is the probable diagnosis? What are we thinking? Right upper limb. So mainly left cortex should be involved. Left lower limb, right cortex should be involved. So two different anatomical sites are there for the lesions, what they have been mentioned here. It cannot be explained with any one of this following. So it has to be multiple sclerosis, usually seen in females. And usually they'll have some amount of vision involvement. And the image what they are given is suggestive of an papilledema. This you can see the margins are blurred here and there is raised blurred margins of optic disc is present, suggestive of an papillary edema. A 45 years old female came to the ED with a fever and cough. She gives an history that after a bout of cough, she had a syncope. This is known as cough syncope. She had no similar episodes in the past. Observation shows an respiratory rate of 15. They look completely fine. You diagnose it as a cough-induced syncope. What is the DVLA guideline they're asking? For a cough-induced syncope, restrict driving for 6 months. 6 months, it is what you need to remember for the first episode. If it is more than one episode what the patient is having, then it becomes 12 months. A 8 years old female child was brought to the ED with ongoing seizures. Mom has gone and given one dose of a buccal midazolam. Paramedics have given another dose of buccal midazolam. So two doses of benzodiazepine have already been given. The patient is received in the resuscitation bed. The cardiac monitor is connected. High flow oxygen via and non-breathing mask is started and the IV line is secured. What is the next best step they are asking here? Two doses are given. So next in the second line of drugs. So in second line of drugs, levetiracetam is preferred over phenytoin and phenobarbital. So right answer here is levetiracetam. A 48 years old male present to the ED with a bilateral lower limb weakness due to the disease associated with the pain. He denies any weakness of the upper limbs, vision, or speech problem. He had no similar complaints in the past. There is no changes in the bowel and bladder habits. On examination, the patient is completely stable. The reflexes are absent. Reflexes are absent. Lower limb involvement. Upper limb is fine. Think of Guillain-Barré syndrome. Straightforward. Bilateral, when it comes, it kinds of rule out all the strokes what you are having. This has appeared in September 24 also. 56 years old female presents to the ED with complaints of a left-sided headache and distribution is describes it as a shooting type of pain. It is worse on talking or chewing food. She is a known case of migraine, but says it is different this time and regularly painkillers are not working. Regular painkillers are not working. She is requesting for immediate painkiller. Which one of the following will be the most appropriate? So what are we thinking here? We are thinking of a trigeminal neuralgia. So the diagnosis here is trigeminal neuralgia. So the treatment choice is carbamazepine. Gabapentin, pregabalin are all second line of drugs. A 68 years old female presents to the ED with complaints of right temporal headache with the right-sided vision, mild vision loss. She has been to the GP a couple of days back, who has reassured her and not started on any treatment. The headache has worsened so much so that it is interfering with her regular day-to-day activities. What is the next best step management plan? So what are we suspecting? Temporal arteritis, what we are suspecting here, because there is a visual loss and temporal headache what the patient is having. Classical presentation of a temporal arteritis. High flow oxygen is for cluster headache. We cannot discharge this patient by just referring to. Referring to the GP also doesn't make sense. Intranasal triptans again for cluster headache what we give it. Out of the options what you are given, refer to the ophthalmologist is the most appropriate. But what we usually do before we are referring to the ophthalmologist, steroids needs to be added. Along with the ophthalmologist, we also refer to the rheumatologist. What do you need to remember? A 66 years old male present to the ED with an episode of syncope. On examination, the patient is stable. Routine examination are completely fine, including the ECG. You are not able to find a cause for the syncope, but you do not think it is an vasovagal syncope. You advise him not to drive, but he insists that he needs to drive so that he can take care of his sick wife. What driving advice will you give to him? So, what is the diagnosis here? It is an unexplained syncope. First episode of an unexplained syncope is the diagnosis we are having. We don't know. It is not a vasovagal syncope, we are sure, but it is unexplained. Why patient had loss of consciousness, we are not aware. So what we do in this point of time, 6 months, we tell them and we had asked them to involve the DVLA. Allow him to drive, he cannot do it. Inform the DVLA if he refuses to do so. Yes. If he doesn't agree not to drive, you need to inform. 1 month, no, it should have been 6 months. 9 months, again wrong. 1 year, again wrong. So the right answer here is the second one, inform DVLA if he refuses to do so. A 64 years old male present to the ED with complaints of loss of a balance and numbness in the limbs. The patient is stable. You get NCT brain, which shows lateral medullary syndrome. Which one of the following you expect to be commonly seen on examination? So lateral medullary syndrome. What and all will is involved? Fifth cranial nerve is involved. After fifth, eighth, ninth, and 10th cranial nerves are involved. Sympathetic chain is involved. Spinothalamic tract is involved. So S and S. Sympathetic chain will cause ipsilateral Horner syndrome. So ipsilateral Horner syndrome is given here. Rest of the following doesn't appear. Ipsilateral numbness, no. It is a contralateral receptive dysphagia is not seen. Contralateral limb ataxia, no. Rigidity, no. So ipsilateral Horner syndrome, what you're seeing. So you need to remember the cranial nerves and remember the sympathetic chain and the spinothalamic tract. Then the answering will become easier for you. A 68 years old female unknown case of hypertension present to the ED with the right temporal headache. It is associated with mild blindness in the right eye. You are suspecting temporal arteritis. Presence of which one of the following will suggest an alternate diagnosis? Increased pain and chewing seen in temporal arteritis. Scalp tenderness seen in temporal arteritis. Myalgia can be seen in temporal arteritis because it is associated with polymyalgia rheumatica. It is seen. Raised ESR, yes, it's an inflammatory marker, can be seen. Ipsilateral facial drooping. It is seen in either in a stroke, upper motor neuron lesion causing an seventh cranial involvement, or it is seen because of an brain stem stroke or an Bell's palsy. You need to think of a differential diagnosis here. So ipsilateral facial drooping is the right answer. A 30 years old male present to the emergency department with complaints of bilateral lower limbs weakness. And he is recently diagnosed with diarrhea and vomiting on the counter medications he has taken, completely recovered. He denies any other symptom unless in the past. He's strongly suspecting an GB syndrome. Which one of the following is seen in GB syndrome? Gowl, glove-like distribution of the weakness. No, it is an ascending. Upper limbs are not involved initially. Weakness of the upper limb is more than the lower limbs. No, it is seen in central cord syndrome. Bilateral poor motor deficit. It is not a pure motor deficit. Okay, some sensory involvement can be seen because only the myelin sheath is involved. It is not a neuromuscular junction disorder. Ascending symmetrical weakness. Yes, that is the right thing which we see in GBS syndrome. Descending symmetrical weakness is seen in botulinism. A school bus driver suddenly lost consciousness while he was in the canteen having food. He gained consciousness. He had no limb weakness or seizure-like activity. He gives a history of having vomiting and diarrhea a few days back. His all vitals and routine investigations are normal. Which of the statement is true regarding his permission to drive? So what are we thinking about here? This is again a syncope. Do we know the cause of syncope? No, it is an unexplained syncope what the patient is having. Unexplained syncope, 6 months he shouldn't be driving. So 6 months and inform the DVLA is the right answer here. So it's the same thing. It is actually, this is taken from the government website. I'll be posting the website. What I told is the same website, what I'll be posting it. You can go through it. This one will give you the more, this is the vasovagal one, what I put up here, the wrong one for this one question. But I'll put up the link itself so that you can easily go to the link. A 69 years old male was brought to the ED with severe headache and vomiting. On assessment, the patient's heart rate, blood pressure is on the higher side. CT scan is shows an intracranial bleed. What is the most appropriate? Reduce the blood pressure. Which is the drug of choice to reduce the blood pressure? All the drugs what you are given here are antihypertensive medications. Preferred one is labetalol. This is a difficult question which appeared in the last diet. Okay. Few parameters we need to be aware of. What is Parkinson's? Parkinson's is a disorder where substantia nigra is involved. Okay, when substantia nigra is involved, what happens? There is decreased dopamine secretion. Okay, that's why we keep on treating the patient with levodopa, all those parameters. Next thing is what is psychosis? Psychosis is exactly opposite that of the Parkinson's what you are having. Okay. So the drugs what you are giving, the antipsychotic medications like an haloperidol what you are giving or an risperidone what you are giving, those are all antipsychotic medications what you are giving. So antipsychotic medications you are giving. This antipsychotic medications, because it is opposite to each other, this is the treatment what you are giving. If you give in a large dose or the side effects of this will be very much similar to that of the Parkinson's. Okay, the side effects are very similar to the Parkinson's. What are these side effects what I am talking about? Side effects, it might be like acute dystonia, which is very common side effect what you're seeing. Acute dystonia, neuroleptic malignant syndrome as in side effect. Okay, this is the basis what you are having here. So we will read this question and get back to this again. A 81 years old male was brought to the ED by ambulance. He is a known case of Parkinson's, hyperlipidemia, gout, enlarged prostate, depression, multiple comorbidities. His caregivers report that he has been agitated, aggressive, not acting like himself. They also mentioned that he has not taken his regular medications several days, which includes levodopa and citalopram. Citalopram is an SSRI. Findings are given here. There is and raised temperature is present in this patient. Okay. And there is noticeable muscle rigidity also present. Given this information, what is the most likely diagnosis? What they are asking. We have not learned about neuroleptic malignant syndrome, but the right diagnosis here is neuroleptic malignant syndrome. We will be learning this in the psychiatric chapter. Okay. So what has actually happened? He has stopped taking levodopa and citalopram. So he has stopped taking these medications. Okay, as he has stopped taking citalopram, it cannot be serotonin syndrome at all. That's how you rule out this one. Malignant hypothermia is only seen in anesthetic drugs. So this one also you will rule it out. Heat stroke and heat exhaustion can easily rule it out. It doesn't say he was externally out somewhere in an hot environment to say an heat stroke or heat exhaustion. So he easily can rule out and come to this diagnosis. But I am not sure these were the options which were given. So remember what has happened here. Again, going back to here, he has stopped taking his levodopa. He has stopped taking his levodopa can cause worsening of the Parkinson's. Worsening of the Parkinson's are nothing but like an side effects of that of the antipsychotic medications. One of the side effect of antipsychotic medication is neuroleptic malignant syndrome. That's why the right answer here is neuroleptic malignant syndrome. Okay, I am sure that there was an serotonin syndrome mentioned and malignant hyperthermia mentioned. I'm not sure about heat stroke and heat exhaustion was mentioned or not. But I'm sure about the answer. This is the neuroleptic malignant syndrome. This is what happens. You need to remember Parkinson's and psychosis are opposite to each other. The differentiating factor between serotonin syndrome and neuroleptic syndrome, we will be learning in our psychiatric chapter. Here you can easily differentiate because he has not taken any serotonin drugs. They should be taking some serotonin drugs. Citalopram, he has not taken at all what they have mentioned. He has not taken his regular medications. Citalopram. So it cannot be an serotonin syndrome. That's how I have ruled it out. There are differentiating factors which are present, which we'll be learning in the psychiatric chapter. A 39 years old female present to the ED complaining of shortness of breath, has been experiencing weaknesses in the lower limbs for past few days, has a history of diarrhea for a couple of days for which she has not sought any medical attentions. Vital parameters seem to be fine. There's certain amount of subtle hypoxia is present. What is the most of definitive management for this patient? Definitive management, IV immunoglobulins. Why? It is a GBS syndrome. Why? Why? Because this patient had an diarrhea. After diarrhea, the patient had lower limb weakness. It is ascending paralysis. So diarrhea, Campylobacter jejuni is the organism which has produced antibodies against the myelin sheath. So the lower limbs are involved. Slowly, the diaphragm got involved. That's why the patient is having shortness of breath. So diagnosis is a GPS. What is the definitive treatment for GBS? Is IV immunoglobulins. Definitive, they are asked. Intubation is not a definitive treatment. Saturation of 91%. Again, you need to start oxygen and all, but definitive treatment they're asking here, IV immunoglobulins. Definitive, not the next best step. Definitive treatment they're asking. Plasma exchange is also a definitive treatment, not preferred. Preferred one is IV immunoglobulin. A 43 years, 43 years old male presented with complaints of weakness and double vision. Okay. Weakness and double vision. Double vision means we are suspecting some cranial nerve. Either whenever the double vision is there, suspect and cranial nerve involvement. Either third, fourth, or sixth cranial nerve involvement, which are supplying the extraocular muscles. He has a recent history of diarrhea and vomiting over the past few days. No similar complaints, episodes, or comorbidities. On examination, the vital parameters are normal. Examination findings are bilateral ptosis, dilated pupils, muscle strength is upper limbs are more than the lower limbs. You're strongly suspecting botulism. Which of the following is not typically seen in botulism? Dysarthria can be seen if there is involvement of 10th and 12th cranial nerve can be seen. No sensory defects. Yes, that is true because it's a neuromuscular disorder. No sensory involvement will be there at all. Typically, respiratory failure can be seen, not very typically seen. Okay, respiratory failure can be seen, but it cannot be typically seen. Dysphagia can be seen. Respiratory failure can be seen, typically, not very typically, but can be seen. Ascending paralysis is not seen. It is a descending paralysis. What you need to remember, it's a descending paralysis. So the right answer here is the first one. Okay, this one 36, the last few questions what we have discussed appeared in the last diet itself, out of which one question was the difficult one. Was the difficult, sorry, one question was the difficult one. This one was the difficult question what had appeared. We do not have complete understanding. Once we learn the psychiatry about the neuroleptic malignant syndrome and Ceridian syndrome, we'll have the better understanding. About the extraocular muscles will be taught in the ENT chapter, ENT and ophthalmology chapter, we'll be learning there. Anyone has any doubts, you can ask me. Otherwise, here the class ends. Anyone has any doubts, you can ask.